way, which is known as a stress-strain curve. And you need to be able to draw one of these in the exam. So stress is basically force per unit area, whereas strain is change in length divided by the original length, and it has no units. So a typical stress-strain curve is formed as follows, and there's certain regions I want to draw your attention to. So when you apply a load or a stress to a material, it will change in length, but in a pretty consistent manner. So the stress and strain will be directly proportional, and this is known as the elastic region. And that's important because if you take the load away, the material will return to its original shape. But once you pass a certain point, known as the yield stress or yield point, unfortunately, the material will then change into a plastic region, which means that when you take the load away, it will not return to its original shape. And you'll notice that the curve itself is disproportionate. So it's more steep here and then more shallow there. And that's because as you start to change the length, you have at a microscopic level grains of atoms together which slide past one another, creating these things called dislocations. And these dislocations provide resistance to further deformation of the material, a process known as work hardening. And that's why you don't have a directly uniform appearance to the plastic zone. When you get to this highest level here, the ultimate stress or the ultimate tensile strength, you'll reach a point where the material then will start to sequentially fail until it catastrophically fails. Hardness is a surface property and is a resistance of a material to scratching. Stiffness is basically resistance of a material to deformation, and it's defined by the gradient of the stress-strain curve in the elastic region. Some will also refer to it as the Young's modulus, and every material has its own unique Young's modulus, which you need to know for the exam. Rigidity is resistance of a structure to deformation. So that's quite important because, for example, in a trauma meeting, we're often told, how would you make this X-fix construct more stiff? That's not quite a correct use of terms. It should be, how would you make this external fixator construct more rigid? Because you are referring to the structure rather than the individual material. The Young's modulus, I've already mentioned, the gradient of the stress-strain curve in the elastic zone. Viscoelasticity is time-dependent stress-strain behavior. A ductile material is one which has a large elastic zone and a smaller plastic zone, whereas brittle is the opposite. And an example of a brittle material would be ceramic. A metal such as titanium would be a ductile material. And these are some relative values of Young's modulus which you need to know for the exam. So the one that's at the top, the stiffest one, is ceramic, then cobalt chrome, then stainless steel. Then you've got titanium, cortical bone, polymer matrix. You then have your you then have your cement. You then have your polyethylene. Then you've got your cancellous bone, tendon and ligament, and finally you've got your cartilage. Okay. I was trying to remember them all off by heart then. So in terms of biomaterials, this can be as simple or as complex as you want to make it. And I'm going to make it simple because I'm a simple guy. So I break it up into 3 metals, titanium, cobalt chrome, and stainless steel, and 3 non-metals, ceramic, polyethylene, and cement, okay? And for each of those, you need to know about the basic structure, and you break that up into 4 categories: composition, manufacture, properties, and use. Okay, so if you learn those 4 things for each of those 6 biomaterials, you will be in great position for the exam. So the question for me is, what material do I choose? Because it's really all about decision making. So it really does vary depending upon the specific situation. For something like this, an arthritic hip, I want a stem which has good load sharing properties so that you don't get stress shielding. I want a bearing surface which basically has good wear properties. For something like a pelvic fracture, I want a plate that is basically going to contour well to the pelvis. So it should have good ductility, something like titanium. And for something like this, I want a intramedullary device, a nail which has good load sharing properties. So it should have a similar Young's modulus to bone. something like titanium. And in all those cases, when I learn biomaterials, I try and link it to a clinical scenario because it just sticks in my head a lot easier. So with metals, I want you to break it up into generic properties of the metal, how they're manufactured, and then specific properties for each metal. So in terms of generic properties, I break it up into microscopic and macroscopic. And at a microscopic level, basically, a metal is made up of atoms joined by bonds. But the key thing about these bonds, guys, is they've got to be strong enough to allow movement. Sorry, strong enough, but still allow some movement. Because remember, you want to bang the metals or twist them into a certain shape. So they've got to have ductility, okay? So the atoms have got to be strong, but still there's got to be an element of delocalized bonding to allow movements. And the way that this works is basically bonds can be formed between metal atoms that have low electronegativities. So they don't attract all of their valence electrons, which surround them very strongly. That means the outermost electrons can be shared between multiple different metal atoms. So this results in a load of metal positive ions, which are known as cations, surrounded by a sea of electrons, which is referred to as an electron cloud, okay? And because these valence electrons, which you can see in this picture here, are shared by all of the atoms, they're not considered to be associated with one specific atom. This is very different to ionic or covalent bonds, where electrons are held tightly by one or two atoms. So the advantage of this is it means that the metallic bond is strong and uniform, but because the electrons are attracted by multiple atoms, it gives you mobility. And that gives properties such as ductility and also electrical and heat conductivity that you see in metals. The other thing to note is above their melting point, metals are liquids with their atoms being randomly arranged and free to move. However, when you cool metals below their melting point, they become rearranged to form ordered structures known as crystals, okay? And in order to form the strongest metallic arrangement, the crystals are packed together in different structures. You do not need to know these in any specific detail, but there's three for the exam. Hexagonal close packed is where there's the tightest packing of metal atoms, face-centered cubic, and then body-centered cubic, okay? With these two, each atom is surrounded by 12. With this, each atom is surrounded by 8. I wouldn't go into any more detail than that. So we then move on to the macroscopic structure, and we've kind of described this already. So this would be your sort of stress-strain curve, but also properties such as ductility, and also chemical properties such as resistance to corrosion, and also conductivity. So microscopic and macroscopic. So let's talk about manufacture of metals in general. And I break it up into a certain number of stages, okay? So first of all, casting is where you put your liquid metal into a certain mold. Wrought is where the cast material becomes modified by rolling and extending it. Cold working is where you forge the metal into new shapes by cold rolling at room temperature, which is a stress level below the ultimate tensile strength. Now, this increases the dislocations and resistance to movements and is also known as work hardening, okay? Annealing is basically where you shift the stress strain curve to the right, so you make it more ductile and basically heat it to half of its melting point, and therefore the grain structure will reform. It decreases the number of dislocations, so it makes it more ductile. Whereas hot working is where you basically heat it above the recrystallization temperature, approximately 60% of the melting point. Shaping is where you put it into the required shape. Alloying is where you add other elements to change the properties. Quenching is where you immerse it in cold water or oil. And then passivation is where you have an oxidation layer on the outside, which gives resistance to corrosion. And this is quite important to note because it's the volume of the passivation layer which often gives your property of how good you are at resisting corrosion. I just want to draw your attention as well to these three terms here. These three in combination make up what we call work hardening, where you're changing the properties of the metal by shifting the stress strain curve either to the left, making the metal more brittle, for example, cold working, or to the right, making it more ductile, which is known as annealing. And it's a combination of these which give you the property of work hardening the metal. So in terms of specific metals, as I mentioned, there's three you need to know. stainless steel, titanium, and cobalt chrome. Okay, and for each of those, I want you to think of composition, manufacture, properties, and uses. So stainless steel, it's got the formula 316L, and that's because it's made up of 3% molybdenum, 16% nickel, and low carbon, 0.03%. There's also 60% iron and 20% chromium. Titanium, oh sorry, in terms of, so that's the composition. Manufacture, we've already talked about. In terms of the properties, stainless steel is stiff. It has a relatively high Young's modulus. It's ductile, it's tough, and it's cheap. And it has reasonably good fatigue resistance, but it's not as good against corrosion, stress, or crevice corrosion. And we mainly use it for plates and screws, but occasionally for femoral stems as well. Titanium has the formula Ti64V, and that's because it's got 6% aluminium, 4% vanadium, and 90% titanium. Manufacture, we've already discussed, general manufacture of a metal. Properties, titanium, the key point is it has a self-passivation layer, so it's very resistant to corrosion. It's biphasic, it has both an alpha phase and a beta phase, so that gives it good fatigue resistance. It's got less modulus mismatch. It's got a very similar Young modulus to bone. So that means you get less stress shielding and less anterior thigh pain because it's sharing the load between the bone and the implant. So it's very good for stems and nails. It's biocompatible, but the downside is it's very sensitive to notch sensitivity. So it's got terrible notch sensitivity properties, which means if you sustain a crack, it will wear away very quickly. It's got terrible wear properties, so it's not good as a bearing surface, and it also gives off vanadium particles if it does wear, which can be cytotoxic. So it's used as a stem, a nail, anything for load sharing, but also some plates as well, because it's quite ductile, particularly for pelvic plates. And finally, cobalt chrome, which has the equation 60-25-5, because it's made up of 60% cobalt, 25% chromium, and 5% molybdenum. Now, this has a very high modulus of elasticity. It's stiff, so it causes stress shielding. So it's not good as a plate or a nail. It has excellent wear properties, high fatigue strength, relatively corrosion resistant, but it's expensive. So it's used as a bearing surface, okay? So in practice, a tibial nail, titanium, okay? You want something load sharing. A femoral head, cobalt chrome, great wear resistance. A plate, stainless steel or titanium. So we then move on to the non-metals, and there's three you need to know: ceramic, polyethylene, and cement, and use my same structure: composition, manufacture, properties, and uses. So let's start with ceramic. This is composition-wise, it's made up of a group of metallic and non-metallic elements which are joined by covalent bonds. It can be subdivided into bioinert ceramics, such as alumina or zirconia. So zirconia has better wear resistance, has better fracture resistance. Alumina has better wear resistance. Oxinium, which is oxidized zirconia, and then also bioactive ceramics, such as hydroxyapatite. In terms of manufacture, it's done by mixing ceramic powder and water together and pressing it into a prefabricated cast. It then undergoes sintering or hot isostatic pressing, which increases the density, but also increases the porosity. Remember my favorite term, everything in orthopedics is a payoff. So you might increase the density, but you also make it more porous. Finally, you get transformational toughening, which is where you add other elements into the mix to toughen the ceramic up and make it less brittle. And that's used in the ceramics that we see nowadays, such as Biolox Delta, where you put strontium in as well. In terms of generations of ceramic, there's 4 to know. So the first generation was just simple alumina or zirconia, very long sintering times, porous, high grain size, so it was susceptible to crack propagation, and that was in the 70s and 80s. The second generation is where you started to mix magnesium oxide and micro arc oxidation as sintering aids to decrease the grain size. You want to get the grain size as small as possible, so that decreased the fractures, and that was from 1988 to 1994. The third generation is hot isostatic pressing, laser etching, and proofing, which gets the grain size even smaller still. And you also decrease crack propagation and fractures. And then the fourth generation is the Biolox Delta, the one we all know and love, which is where you get your alumina matrix composites, mixture of alumina oxide, 70%, 5% of that, zirconium oxide, but also bits of chromium oxide and strontium as well.
Sorry, Dr. Rishi, is your slide moving or?
No, I'm just talking. I'm going to move it through in a second. Sorry about that. No. So this is just the talking bit. So yes, so this also combines the mechanical properties of all of these. So just remember those 4 generations of ceramic. And as you said, I'm going to move the slide now because I showed you this bad boy a bit too soon. So this guy here was a hero of mine, a musical hero. I don't know if you guys know who he is, but his name is Mr. Barry White. Rest in peace. So this is my mnemonic that I've created for the properties of ceramic. And I want you guys to remember this for the exam. So remember, B White for Barry White. B is brittle, although the new generations of ceramic are less so. W is wettable, which means it has a high affinity for lubricant. H is hard, it's got resistance to scratching. I is inert, it's not chemically reactive. T is transformational toughness. And E is efficient, it's got a low coefficient of frictions. So its use is it's great as a bearing surface. But the downside is it's brittle. And also you get this thing called squeak. Squeak is a problem mainly with the newer ceramics where fracture is not really a big problem. And it's defined as a high-pitched sound which is audible to the human ear. And it occurs in mid-range movements. So while weight bearing, such as simulated stairs or climbs. Studies have suggested that squeak doesn't really affect the longevity or function of an implant, but it does appear to be a consequence of disruption of the fluid film lubrication to causing inadvertent metal transfer in a bearing. So anything which increases the metal debris, for example, third body wear, which I'll talk about later, can increase this disruption. I want to mention briefly about crack propagation. Now, this was a big problem in the past with ceramics, basically, is that you've got a crack and unfortunately that would propagate throughout the material and it would fail very quickly. Hence, it was brittle. But there's 2 mechanisms in the newer generation ceramics, the 4th generations, to prevent this. So the first is this thing called conversion reinforcement. So effectively, the zirconium oxide particles act as an airbag. So when you bash the ceramic, basically, it's like crashing your car. The impact gets absorbed by the zirconium oxide, which stops it from propagating, okay? And that means that basically the forces are homogeneously distributed throughout, and so you don't get this crack propagation. The second one is in the form of these platelet-shaped crystals. So in the oxide mixture, you get these platelet-type crystals, as if you've had a bleed, and you're basically clotting off the crack. So that's the way to think about it, okay? Think of it in terms of conversion reinforcement and also platelet shaped crystals as well. That's the 2 ways that you stop crack propagation. Remember the scratch profile as well. So the scratch profile of a metal, when it scratches, it basically sustains little peaks on the surface, which are known as basically asperities. And these are visible on the surface, so it makes it more susceptible to notch sensitivity or wearing away the poly. Whereas with the ceramic, the scratch profile is inside the material itself, so it doesn't rub against the poly. The final thing I want to mention with ceramics is stripe wear. And a lot of trainees ask me, what do they mean by stripe wear? Because it sometimes comes up in the exam. So stripe wear is basically a long, narrow area of damage that you can basically see on some femoral heads which have been retrieved from explanted alumina, ceramic on ceramic hip bearing samples. Now, the key point is stripe wear has been reported in 1st and 2nd generation alumina bearings, but there were also reports of stripe wear in 3rd generation ceramic on ceramic bearings, even with well-fixed and well-positioned acetabular components. It's believed to be caused by edge loading of the implant, but it doesn't appear to have any impact on osteolysis because the particles are so small that they don't activate the macrophages. We next move on to polyethylene. And again, I want you to use my structure: composition, manufacture, properties, and uses. So in terms of composition, Polyethylene is made up of a long chain polymer of ethylene units, C2H4, joined together by covalent bonds. And there's 5 stages of manufacture that you need to know for the exam. So the first one is polymerization, which can be 2 types, addition or condensation polymerization. So addition is where you basically add a free radical to the monomer with a double carbon bond. And so it breaks the bond and occupies the binding site, leading to the formation of the old school high density polyethylene, which was more brittle. Okay, whereas condensation is the newer ultra high molecular weight poly that we see. That's where monomers with symmetrical end groups come together, they react and they lose a water group, condensation, and they bond. So basically, the condensation polymerization gives you a less brittle poly. The other thing to remember is this word called the Ziegler effect, which is where the ethylene gas with a titanium chloride catalyst comes together with low temperature and low pressure to give a powder. And that's the process by which polymerization occurs, guys. Okay, so that's first of all polymerization. The next thing is basically shaping, and that's where you put the polymer together to form the desired shape. And there's 3 main mechanisms. So Rambar extrusion is basically where you use a bar to bash it into the correct shape. You've got sheet compression molding, which is basically where you use a big sheet to put it into the correct shape. And then direct compression molding is where you put it into a direct mold. The key point to remember is that the first 2, Rambar and sheet compression, are bad because they involve machining, which causes chain scission or breakage, and also addition of calcium stearate to the machine, which can weaken the poly and make it more brittle. Next stage is sterilization. So you basically sterilize the poly with gamma radiation, okay, which gets rid of any bugs, but it also does break up the chains, causing free radicals. Remember, everything in orthopedics is a payoff. So the next thing is, do you sterilize in air or do you sterilize in an inert gas such as argon? It's always better to sterilize in an inert gas, okay, because you don't get reaction of these free radicals with the oxygen, which causes early breakdown of the poly, okay? So it's important to note if it was sterilized in an oxygen-rich or an oxygen-free environment. Stage 4 is heating, where you want to get rid of some of these free radicals. So you can either melt the poly down, gets rid of all the free radicals, but makes it more brittle, or you can basically melt it to half its melting point, which gets rid of some of the free radicals, but maintains the biomechanical properties, known as annealing. And finally, you've got packaging. So you've got to make sure you don't package it past its sell-by date. The last thing to mention is that polyethylene exists in 2 forms: a crystalline form, which is more organized and gives you mechanical strength, but less cross-linking, and an amorphous form with basically less strength, but more cross-linking. The optimum crystallinity that you're aiming for is about 45 to 65%. If it's too low, it becomes brittle. If it's too high, you get no cross-linking, so it wears away very easily. And in terms of properties, it's got a similar Young's modulus to bone. It's ductile, it's cheap, and it's resistant to wear. And basically, the last one to let you know about is cement, okay? So cement, the way that I break it down is composition. You've got a powder with 3 components: a copolymer, barium, which makes sure that you can visualize it on X-ray, so it's a radio opacifier, and also an initiator, benzoyl peroxide, or a liquid, which has 3 components: a monomer, an accelerator, N-dimethyl toluidine, which you see in TNT, which speeds up the reaction, and an inhibitor, hydroquinone. In terms of manufacture, there's different phases of cements. So if you see your scrub nurse mixing together the cement, watch her very closely. First of all, you'll get the sandy phase where she's mixing the powder and liquid separately, and you can see them separately. Then the stringy phase where it becomes like pasta. Then the doughy phase where you can start to implant it and where the working time of the cement starts. And finally, the setting or the hardening phase. There's 4 generations of cement that you need to know. The first generation is very rudimentary, simple hand mixing, simple hand packing, loads of voids. The second generation, we introduced pulse lavage and cement restrictors. The third generation, we started mixing in a vacuum to get rid of porosities and also pressurization, because cement is good in compression, but weak in tension and shear. And finally, proximal and distal centralizers in the 4th generation. In terms of properties, it's strong in compression, it's weak in tension and shear, so it's not as good for the acetabulum. It's got a Young's modulus similar to bone. And the key point, guys, is its function. It acts as a grout. There's no chemical interaction between the bone and the implant. Great. So I'm sorry that I went on a little bit longer there. That concludes the first part of my talk. Obviously, if there's any questions, I've seen some for the chat, so we can go through those. And please check out some of our courses as well. So this is a QR code for some of the courses and basic science videos as well. And that's my website. Thank you.
Thank you very much, Dr. Dia. Indeed, yeah, we're just 10 minutes behind the time, but I don't blame you. It's a very big topic. I can see 3 questions. Guys, you can keep until the next lecture for Dr. Rishi. By that time, he will be answering it. So I would ask for the second presentation. Would you share your screen, Dr. Gia, please? Yeah, please unmute your microphone.
Yep.
Dr. Gia. Yeah, you're there. Clear.
Yeah, can everyone hear me? And can everyone see the screen?
Yeah, so it's very clear, and the screen is clear also.
Okay, good morning, everyone. My name is Jared Parlin. I'm a consultant hip and knee surgeon up in Leeds. Thank you very much for inviting me to give this talk. I've given this talk before on a few of the basic science revision courses I teach on. So the title of the talk is Biomechanics of Total Hip Replacement. In 15-20 minutes, one can't cover every aspect of biomechanics. So I'm going to concentrate on the key aspects, which I think a lot of trainees maybe struggle with in terms of principles and concepts. Right, so the objectives, we're going to look at the basic principles of hip biomechanics, some of the definitions, and then we're going to move on to how to have an idea of drawing a free body diagram of the hip. And then finally, we'll look at some of the key things about doing a total hip replacement and the biomechanics involved in doing a total hip replacement. Right. So part of this talk is you need to have an understanding of some of the principles underpinning biomechanics, and therefore you need to have an awareness of what Newton's laws are. So law 1 is that every object in a state of uniform motion tends to remain in that state of motion unless an external force is applied to it. Okay, so you can so essentially an object won't change its motion unless you apply a force to it. Number 2, the relationship between an object's mass, designated m, its acceleration a, and the applied force can be summed up in this equation: force equals mass times acceleration. Okay, so essentially the heavier or the greater the mass of an object, the more force is needed to move that object. And finally, law 3 is for every action there's an equal and opposite reaction. Okay, so some of the definitions. What is force? Force is a push or pull on an object resulting from the object's interaction with another object. Okay, and the units, the standard international units is Newton. So it's the force required to give 1 kilogram mass an acceleration of 1 meter per second squared. A vector is now a quantity that contains both direction and magnitude. Okay, whereas scalar quantities don't have direction. And finally, a moment or torque. This is the tendency of a force to rotate around the body, rotate a body around an axis. So the moment is equal to the force time perpendicular times the distance. The reason these are important is because these help you calculate your free body diagrams around various joints, the commonest one being the hip. So in any free body diagram, you need to make certain assumptions. One, and this you can read yourself, bones are rigid bodies, joints are frictionless, there's no antagonistic muscle action, You assume the weight of the body is concentrated in the exact center of the body mass. You assume that the internal forces cancel each other out and that muscles only act in tension. And the line of action of a muscle is along the center of the cross-sectional area of the muscle. And the joint reaction force is thought to be compressive only. Okay, so these are common exam questions, either in the multiple choice questions or indeed in a Viva. When they ask you to draw a free body diagram, you need to be able to rattle these off very quickly. Joint reaction force is the force generated within the joint in response to the forces acting on the joint. Okay, so we're trying to balance the moment arms of the body weight and the abductor tension in order to maintain a level pelvis. So again, it's useful to have some rules of thumb in terms of how much force is required in order to do various things. So for example, a straight leg raise is the equivalent of 2 times your body weight. If you try and stand on one leg, it's 3 times body weight. Walking is 5 times and running is 10 times. So how to draw a free body diagram. Okay, you need to be able to take a piece of paper and a pencil or pen and be able to very quickly draw a free body diagram. So my suggestion is you keep it very simple. You don't need to have a complicated diagram. You need to literally draw a ball and a circle to represent the femoral head. You need to draw a rough shape of a femur, and you need to be able to draw the center of the body weight, center weight. So you can see here, this arrow here is where we assume the body weight's coming through. You see here is the center of the femoral head, and you see here, that's your abductor tension force, okay? So what you're trying to work out is what the joint reaction force is here, okay? Remember, the joint reaction force is not necessarily straight up, it is perpendicular to the other lines of action. So what you have here, therefore, is the ability now to work out what the joint reaction force is. So A, that distance is the abductor, is the moment around on the abductor side. B is the moment created on the body weight side, and you're trying to match them. And this is the angle between the ground reaction force going straight up and the joint reaction force. So it's the JRF is not the same as the ground reaction force. This is essentially what stops us from floating off up into space, okay? Because if the forces weren't balanced, we wouldn't be staying on the ground. Now, what happens when you therefore add a cane to this? What you're then doing is you're increasing that moment arm across to the other side, the contralateral side, and as a result, you can reduce the amount of joint reaction force going through that arthritic hip. And that is the basis for why we recommend patients who are having excuse me, symptoms of arthritis and pain in the hip to reduce the joint reaction force in that painful hip. We advise them to use a walking stick in the contralateral hand. Okay, so again, remember you need to have your SI units. So force is equal to body weight times G. G is your acceleration, it's your constant, it's the acceleration due to Earth's gravity. It's 9.8 meters per second squared, but you can round it up to say 10. We know that if you stand on one leg, it's 1/6 of your body weight. The rest of the body weight is 5/6. So these are some of the assumptions. So in a state of equilibrium, i.e. balance, the anti-clockwise moment must equal the clockwise moment. So your abductor force, AB, times the distance, plus 5/6 of your body weight times B must equal to 0 because it has to balance. So therefore, your abductor tension times your A distance will equal your body weight times your B distance. Now, if you assume A is, say, 0.05 meters and B is 0.15 meters and your body weight is 60 kilograms, the force body weight, if you assume G is 10, will be 600 newtons. So therefore, 5/6 equals 500 newtons. So now you can work out what the abductor tension force is. So if you've got 500 newtons times the distance, 0.15, divided over 0.05, you will therefore get your abductor tension force, which is 1500 newtons. You can then either use Pythagoras Theorem, in which case you have to have some idea of the sine, cosine, or tangent. Or you can do a bit of a cheat and you can just say, essentially, your ground reaction force, R, is your abductor tension plus your force body weight. So 1500 newtons plus 500 equals 2000 newtons. If you then use your cosine, because that takes into account this theta angle to create your joint reaction force, then it's going to be roughly about 2080 newtons, okay? Limping. Why does limping shorten the body lever arm? It's because you're reducing the joint reaction force by leaning over, okay? So this decreases the force generated by the body weight on the hip. You're trying to bring that distance across, so you're shifting the center of gravity, okay? And that's why patients walk with a Trendelenburg gait. Now we move on to the effect of what happens when you have a different type of either varus or valgus neck shaft angle, okay? So a varus neck shaft angle is 115 degrees. You can see here, it's almost sort of 90 degrees. That's a varus neck. The average neck shaft angle in most people is 130 degrees. So remember, the neck shaft angle is the angle between that line and the line of axis. So it's this angle here, okay? And then here you can see that's 130 degrees if you draw a line like that. And in a valgus neck, so greater neck shaft angle, it's more than 145 degrees. So you get an increased joint reaction force because you've got a lower femoral offset. So you can see here the normal, that's your normal femoral offset. If you have a varus neck, is longer, the femoral offset. If it's a valgus neck, it's shorter, and therefore your joint reaction force is greater. So what are the biomechanical goals of a total hip replacement? You want to restore the femoral offset and the femoral version. You want to maintain leg lengths, restore it. You want to reduce the joint reaction force that goes through that hip. You want to restore the acetabular version and inclination, and therefore reduce edge loading. And you want to make sure the joint loading is evenly distributed. Ultimately, you want to ensure that the joint replacement has minimal wear and maximum stability. So this is an example of for example, a polished tapered stem. And you can see here the various, that's your offsets from the center of the femoral head to the long axis of the stem. You've got your neck length as well. And then so that's, sorry, there, from there to there, that's B. And then finally, you've got your vertical height. On the acetabular bit, you have two things which you need to control for. It's your acetabular inclination or coronal tilt angle, but also your acetabular version, okay? Wolff's law is important. It's the law which basically says that bone will adapt to the load it is exposed to. So if you load bone, it will become stronger in that area as a result of the external forces being applied to it. And it's based on this principle of this crane, okay? And you can see here in the body, in the proximal femur, you have these stress lines which show you the lines of forces in the proximal femur. You may get asked in the viva to draw this diagram to show the tension and compressive forces that go through the proximal femur. An example of why it's important is because if you have an area underneath a hip replacement, for example here, which is not loaded, then you will start getting bony reabsorption and it will start to fail, okay? Can you all see where the arrow is, that this area here is relatively, you get unloaded, and therefore you get stress shielding causing bone resorption. Rishi has already spoken a little bit about the Young's modulus and stress strain curves. Again, it's something that you need to be aware of with regards to biomaterials, and also which materials have a high Young's modulus of elasticity and which have a low Young's modulus of elasticity. The key thing is that you need to know examples of where along that graph, again, it's something you may be asked to draw different materials, including biological materials, or indeed bone. So bone, tendon, ligaments are all along here. All your metals are up along here. And you need to know that, for example, titanium is closer to cortical bone than, for example, ceramic. And that has an implication in terms of the stiffness in the material, because if you reduce the stiffness of the material, you reduce the stress shielding, okay? Offset. Why is femoral offset important? Femoral offset is all about the abductor function, your gluteus medius and minimus, okay? If you increase the femoral offset, you increase the abductor lever arm, and it leads to reduced joint reaction force and reduced wear after total hip replacement. So for example, you can see here one study that showed that the linear wear rate, if you had a standard offset hip replacement, was about 0.21 millimeters a year. If you lateralize it, or you increase the offset, you can reduce that by half, okay? Now, correspondingly, you don't want to increase the offset too much, because you then get problems with tight abductors, and it can cause problems with the bursa around the trochanter area and cause pain and lateral pain. So it is a balance. This is showing you what the impact of the femoral version is on the functional femoral offset. So if you have an extreme amount of femoral anteversion, 35 degrees, then you come down to your normal femoral anteversion in most people is around 10 degrees, and you go down to retroversion. What you're doing is you are increasing the femoral offset, decreasing the joint reaction force, but potentially increasing instability. So there's always a compromise, okay? You want to increase the femoral offset a bit, but you don't want to increase it so much that you get an unstable hip. This is what happens with the acetabulum. So I said to you, there were two things that you need to be aware of with the acetabulum. It's the inclination of the acetabulum as well as the version of the acetabulum, okay? And the cup abduction angle is measured as the angle between the interteardrop, okay, and the major axis of the cup projection. So if you can see here, B, that's your 45-degree angle. So when we do a total hip replacement, we tend to, as a rule of thumb, aim for about 40 to 45 degrees of sitting the cup at an inclination, and we aim for about 15 or 20 degrees of anteversion. Now, that is probably not particularly accurate. That is based on studies from many, many years ago on a few number of patients, and we now know that it's far more complex than just putting every cup in 45 degrees or 40 degrees inclination and 20 degrees anteversion. It depends a bit on how stiff the spine is, on the patient's natural femoral acetabular geometry. And so there's a lot of work going on now to try and individualize how patients are, and in order to recreate the natural femoral and acetabular offset and inclination. So that is why you can sometimes see patients who have what looks to be a very normal, very well-placed acetabular component and femoral component who still maybe get dislocation. So the key thing in all of this is it is not just one or the other, but it is your combined femoral and acetabular anteversion, which helps maintain your appropriate abductor tension. If you've got too tight an abductor, you will get a tight iliotibial band and trochanteric pain and tight abductors. If there's too little abductor tension, you get instability, okay? The head-neck ratio. So you get decreased dislocation rates because if you increase your head-neck ratio. So the head-neck ratio is defined as the diameter of the femoral head relative to the diameter of the femoral neck. So the larger the head-neck ratio will allow you for a greater arc of range of motion before you get impingement, okay? So if the head size, small head size, you'll get less volumetric wear, okay? Because secondary to a smaller arc of motion, but you'll get greater linear wear because the joint reaction force is distributed over a much smaller area. So again, everything we do in the total hip replacement is about balancing risk. So the 28 to 32 millimeter head is thought to be the appropriate balance to balance volumetric and linear wear. If you have hard on hard articulations, you tend to get hydrodynamic lubrication and low volumetric wear. So designing the aspects of the acetabulum component. So you're looking at three things. You're looking at the head size, the taper diameter, and the cup entrance plane, which is a hemispherical versus a subhemispherical socket. I think this is probably in a lot of detail. If you're already talking about this sort of concept in the Viva, you will have been doing very well. And finally, this just tells you where to put the position of the acetabular cup in order to reduce or increase the hip reaction force. So if you put the cup 1 centimeter superior, posterior, and medialized, you can increase the hip reaction force more than normal. And this was based on a cadaveric study. So in summary, I think it's important to just keep to basic principles. You need to know how to draw a free body diagram. I'm very happy to go through things afterwards because it's hard to do it unless you practice drawing a free body diagram. If you increase the abductor lever arm, either by increasing the medial offset, or you can reattach the greater trochanter distally or more laterally, you increase the abductor lever arm. Your joint reaction force is minimal if your hip center is anatomical. If you change the neck length, it can affect both the medial and vertical offset. If you restore the neck, too much anteversion, you get anterior dislocation. Too much retroversion, you get posterior dislocation. If you increase the head-neck ratio, you get a greater arc range of motion before you get impingement. And if you use a contralateral cane or Trendelenburg gate, you can reduce the joint reaction force. Okay, thank you.
Thank you very much, Dr. Gia. I can see a couple of questions if you're happy to answer them by typing, but I'll just pick one of them so for the public. So one anonymous attendee asked if Varus neck produces longer femoral offset and better abductor function. Why in idiopathic coxavara the patients present with Trendelenburg gait? Sorry.
Well, it depends on, so Trendelenburg gait is due to an abnormal abductor function, okay? So it's slightly different, so abnormal abductor function, which may then lead to pain or decreased biomechanical imbalance, etc. So in idiopathic coxavara, it may well be because it's to do with an imbalance in their abductor function rather than because of pain. So although the offsets, it's something that they have grown up with. It's not something that's occurred suddenly and therefore they've changed. They've grown up with that all their lives, and therefore their muscle balance compared to the normal person is abnormal. And that probably is why they have that Trendelenburg gait, albeit not because of pain.
Thank you very much. You may answer the other questions.
Limping and hip OA, well, it's a bit of both. People don't want to stand on a painful hip joint. So as a result, they have a short stance phase on that affected leg. But they also want to walk with less pain. So as a result, it's probably a combination of short stance phase, but also trying to offset the body weight to reduce the amount of joint reaction force going through that arthritic hip. So it's a combination of both.
Okay, thank you very much, Dr. Gia. I would ask Dr. Rishi again for tribiology.
Sorry, can you guys see that okay?
It's a whiteboard.
A whiteboard, okay. Sorry, I'll just do that again. So I'm just going to share my screen and I'll share that now. Just tell me if that's okay. Can you all see that?
Yeah, the barcode one.
Good, excellent. Right, okay, guys. So I'll try and rush through this as quick as we can. This is the second part of my talk. Now, I've talked to you guys about choosing the right material, but unfortunately, we don't use materials in isolation. We use them in combination. So it's really important to understand about material interactions. And that's where tribology comes into play. It's the science of interaction. Now, not all interactions such as this one are positive interactions. Some can be negative as well. So you've got to know about all of these. So I break tribology very simply down into three parts: friction, lubrication, and wear. And I want you to remember this triumvirate. So friction turns the tap of wear on, lubrication turns the tap of wear off. But your ultimate end goal is you want to prevent wear, okay? So let's start with friction. Friction is basically resistance to sliding between two bodies in motion, okay? So you can classify it as both dry and wet friction, and also static and dynamic friction in terms of dry. Static at stillness, dynamic when it's on the move. In terms of the effects, well, friction basically causes loss of energy. It increases the amount of effort you need to move a joint and therefore the load on an implant. And ultimately, it's bad news because it increases wear. So there are some laws that you need to know, which were devised by Newton. The first one was that frictional force is equal to the coefficient of friction. Now, this is a non-variable thing, and it's specific to the individual articulation, the coefficient of friction between two materials, times by the load. Obviously, the load does vary. So if you get a higher load, you get a higher friction, okay? The other one is force is independent of apparent contact surface area. Now, you might say, what does he mean by that? But I'll come on to that in a second. And the third one is that your kinetic frictional force is independent of sliding speed. So when there's friction on the move between two surfaces, it doesn't matter how quick or slow they slide past each other, the frictional force will be independent of that. So I want to go through some concepts of friction. And this concept particularly of the apparent and true contact surface area. Now, I've just told you in the previous slide that frictional force does not depend upon the apparent contact surface area. So what do I mean by that? Well, let's say we put a wheelbarrow on a slope. Basically, the apparent contact surface area would be the bits of the two surfaces which appear to be touching each other. However, at a microscopic level, not all parts of the surface will be in contact with each other. So only where they have projections called asperities, which are touching. So that is the true contact surface area. So in fact, the true contact surface area is much smaller than the apparent contact surface area. Now, when we increase the load, that increases the amount of stress inside the asperity. So basically it causes it to squash down and deform by plastic deformation. So it will increase the true contact surface area. And that's why Newton's first law that load is proportional to friction holds true, because if you've got a bigger load, you've got a bigger contact surface area, true contact surface area, okay? So the reality of Newton's law is it should be frictional force is independent of apparent contact surface area, but it's dependent on true contact surface area, okay? And it just means it's inversely proportional to hardness, because if a material is harder, it's got fewer scratches, so it's got fewer asperities, so the true contact surface area will be smaller. Static friction is generated by bonds between asperities, so asperities are bad. And roughness looks at the mean height of the asperities, and that's specific to each individual material. Whereas the coefficient friction depends upon a combination between different materials. And you can have static or dynamic coefficients of friction. So the key thing is you probably have to learn this table for the exam. Each material has an individual mean surface roughness. I'm not going to go into that in any particular detail. I'll just leave that up for a second for you guys to learn for the exam. And also the coefficient of friction of the different articulations. Again, you need to know this for the exam. The only thing I want to draw your attention to is look how low it is for the native knee and the native hip. So that means that your native cartilage is always going to be better than the best joint replacement in the world. You cannot compensate for the true joint or true articulation. So we then move on to liquid friction, which is known as viscosity, okay? And viscosity is basically the internal friction of a fluid. A shear is the force required to move one layer of fluid relative to another. So a shear will occur, for example, when you shake a liquid or if you pour a liquid out. And basically, the more viscous a fluid is, the more shear force you need to move each layer of fluid relative to the other. So Newton devised this formula basically, which said that viscosity equals shear stress over shear rate. And any liquids which obey that rule are known as Newtonian liquids. So that means if you vary the shear rate, the shear stress will vary at the same proportion. And an example of that would be water, thin motor oils, or rheumatoid synovial fluid, which has been degraded by enzymes. So you will need to know about Newtonian versus non-Newtonian fluids. Non-Newtonian fluids are ones which do not obey that formula. So that means that when the shear rate is varied, the stress does not vary to the same proportion or direction. And it can be further subdivided into a pseudoplastic or a dilatant fluid. So a pseudoplastic one is a shear thinning fluid. So that basically means that the viscosity decreases as the shear rate increases. For example, paints, emulsions, or synovial fluid, whereas a dilatant fluid is a shear thickening fluid where the viscosity increases as the shear rate increases. Okay, so an example of that would be things like treacle. Okay. You also have time-dependent rheological behavior. Rheology is just the science of flow of matter or deformation. And time-dependent increase in viscosity in response to a constant shear rate is known as rheopexy, whereas a time-dependent decrease in viscosity in response to a constant shear rate, similar to stress relaxation, for example, a synovial fluid, grease, or paint is known as thixotropic, okay? So synovial fluid is defined as a dialysate of plasma minus hemoglobin, clotting, and erythrocytes. And this is a common question in the MCQs, guys. So synovial fluid has got these three properties. It's non-Newtonian. It doesn't obey that equation. It's thixotropic, so it's got a time-dependent decrease in viscosity in response to a constant shear rate. And then also it's pseudoplastic or undergoes shear thinning as well. And it functions as a natural lubricant, okay? So we have this game in the UK called Who Wants to Be a Millionaire? I know they have it in India as well. And for $1 million, which of these does synovial fluid not display? Well, the answer is, my friends, shear thickening. It has all of the other three properties. So we then move on to lubrication. We're now turning the tap of wear off, okay? So lubrication basically is good. And the type that you get depends upon the lambda ratio. And the lambda ratio is defined as the thickness of the film of fluid divided by the thickness of the asperities, essentially, okay? And boundary is when you've only got one layer thick between the two surfaces with a ratio of less than 1. Boundary is bad. It's going to cause lots of wear. Whereas fluid film, I always think it's like the sensation of walking on air. You've eventually got a lambda ratio of greater than 3. You've got a really thick film of fluid between the two surfaces, much more than the height of the asperities or the roughness, okay? You need to know about lubrication of the native joint and the prosthetic joint. And I would break the native joint up into 3 static and 3 dynamic types, okay? And you need to know about the types which occur during the gait cycle. And these are all parts of the fluid film lubrication that you see in the native joint, okay? With the prosthetic joint, you try to get fluid film, but you mainly get boundary or a mixture of the two, okay? And you need to know about this concept of ideal radial clearance. And I'm going to talk to you guys about the Goldilocks phenomenon. That's something that I've made up. It's not in the book, so don't quote that in the exam, but it's just a way of remembering it. Okay, so types of lubrication that you get. You can break these up into 3 static and 3 dynamic, okay? And the static ones will be, for example, squeeze. So 2 surfaces, bearing surfaces, come together without sliding, and fluid is forced from the gap and generates a hydrostatic pressure that can bear a load for as long as the fluid is squeezed out. For example, a heel strike. Boosted is where the surfaces are squeezed together, but this time water moves into the cartilage and increases the concentration of hyaluronic acid in the gap, whereas weeping is where the surfaces are squeezed together and water is forced out from cartilage into the gap, hence you are weeping tears of lubricant. The dynamic types, you've got hydrodynamic, which basically assumes that the surfaces are rigid, the bearing surfaces, and you've got a high velocity, a low load, and a high viscosity. Now, the problem is you very rarely have that in real life, so it only really occurs during the swing phase of gait. Elastohydrodynamic assumes that the cartilage is deformable, which is probably a more realistic representation of what happens. And this time, as it deforms, it basically traps fluid and basically increases the surface area, okay, of lubrication. And finally, micro-elastohydrodynamic is where you've got deformation of the asperities at a microscopic level. So in the native joint, you basically have at different phases. In the heel strike, you get squeeze. During stance, you get elastohydrodynamic and micro-elastohydrodynamic. In prolonged stance, you get boundary or boosted. In toe off, you get boundary, weeping, and micro-elastohydrodynamic. In swing, you get hydrodynamic. So those are the phases that you need to learn in different parts of the native gait, okay? And I mentioned about the dynamic between basically fluid film and boundary lubrication. And we define this by something called the Stribec Curve, which you can see here, and also the Sommerfeld equation, which is below. And what you find is that basically when the coefficient of friction is pretty high, you get mainly boundary lubrication. As it gets lower, you start to get more fluid film lubrication. So that's known as the Stribec curve. And you might be asked to draw that in the exam. Finally, in the prosthetic joint, you basically get mainly boundary and mixed, but there is a certain scenario where you might get a fluid film lubrication, metal on metal, hard on hard bearing, where basically you're looking for the ideal radial clearance. And Jay has mentioned this already, but it's basically the difference or the mismatch between the head and the acetabulum size. And I call it the Goldilocks phenomenon, because Goldilocks and the three bears had three types of porridge. One was too hot, one was too cold, and one was just right. So equatorial contact is where the head is too big, so you get fluid lockout. You're not going to get a fluid film. Polar contact is basically where it's too small, so you're going to get just loading here, point contact, and you won't get a fluid film. Whereas mid-polar contact is where it's just right, so you get ingression of fluid and you get the fluid film. And four things affect a fluid film. It's the size of the head and the acetabulum, so it's the radial clearance, the mismatch between the two, okay? It's the surface roughness, the type of bearing material, so metal and metal or ceramic, hard surfaces, you might get a fluid film, and size of the head, and also the sphericity. The goal is to keep it to less than 7 micrometers. Finally, we move on to wear. And wear is where basically it's the endpoint which we're trying to prevent. And I break wear down into, wear is defined, sorry, it's the unwanted loss of material from a bearing surface. So we want to prevent this. And I break it up into how a wear particle is generated. So you can break it into mechanical or chemical. And mechanical can be further subdivided into modes of wear. There's 4 modes, okay? So you've got first degree wear, which is wear between 2 surfaces which are intended to articulate, such as metal and poly. Second degree wear is between 2 surfaces which are not intended to articulate, such as the metal head and the metal-backed acetabular shell. Third body wear is sand or grit in your engine. That's where you've got lots of particles between the 2 surfaces. And backside wear is between 2 non-articulating surfaces, such as the acetabular shell and the native bone underneath it. Types of wear, there's abrasive wear, there's adhesive wear, and there's subsurface delamination or catastrophic wear, which I'll explain now. So abrasive and adhesive, let's say you've got a hard on soft surface, such as poly and metal. As the metal scrapes past the poly, remember it's got asperities on its surface. These asperities from the harder body dig into the softer body and break off bits of poly or wear particles. Adhesive wear is where 2 surfaces come together, but the bonds between the surface are stronger than the bonds within surface. So you get micro welding, and then when they pull apart, bits of material are pulled apart as well. So we see these 2 types in the hip. And it depends really on the balance of the strength between the materials and the bonds between. Now, this is the type you see in the knee, and it's basically where you get catastrophic wear or subsurface delamination in the thin surface beneath the, the thin layer beneath the surface. And basically this occurs because the material is cyclically loaded, which is something called fatigue failure. It's not related to surface roughness. And the key point is to understand about the SN curve and endurance limit. And there's an increased risk if you've got a very thin poly, or it's malaligned, or something goes wrong during one of the 5 stages of manufacture that I spoke about earlier. So you will need to be able to draw an SN curve for the exam, guys. You'll need to know what subsurface delamination is. You'll need to know about the types of wear you get in a hip and knee replacement. You'll need to know how we measure wear. So linear wear is measured in millimeters, volumetric wear in millimeters cubed, okay? And the laws of wear, the volume of wear are proportional to basically the height of the asperities divided by the linear volume times the coefficient. So this is the fatigue failure curve that you need to know. And what that basically says is fatigue failure is failure of material at a stress level below the ultimate tensile stress. So what it means is if you load a material with a very high stress during one cycle, it will fail, but it needs immense amounts of stress for that to fail. But as you continue to load it by walking on it over time, the amount of stress needed for it to fail gradually falls, okay? And the fatigue limit or endurance limit basically is the stress level at which a material can withstand 10 million cycles of loading before failure. And the way that that came about is because we assume that we do 1 million cycles of loading per year. So if a material can withstand 10 million cycles, in effect, it will last 10 years. So your goal as a manufacturer is to keep a material operating at a level below the endurance limit, because in theory, in vitro, it will last forever, okay? So with a hip, it's always operating below the endurance limit because a hip is a very congruent surface, high contact surface area, round on round, low contact stress, therefore it sits below the endurance limit. So in the hip, your priority is wear resistance rather than fatigue resistance. So we use a highly cross-linked poly, which is very good at resisting wear, but not so good at resisting fatigue. Whereas in the knee, you've got a round on flat surface. It operates at a level at or above the endurance limit. So in the knee, your priority is something which is not as brittle, such as ultra high molecular weight poly, okay? And these are examples of fatigue failure in action, both in trauma scenario and also in the elective scenario as well. We'll finally move on to corrosion or chemical wear. And corrosion is basically unwanted dissolution of a material when it's placed in a chemical solution, a metal in specific. And you can break it down into local, crevice or pitting, and general, which is galvanic, fretting, stress, intragranular, and trunnionitis. I'm not going to go through that in a lot of detail, but I can answer that in the chat a bit later on. The key point to remember is some sort of mechanical event happens which disrupts the passivation layer. So it could be at a local level where there's a microenvironment, there's increased hydrogen ions, more acidic. And because of that disruption of the passivation layer, it basically makes it more susceptible to corrosion. And trunnionitis is something which some students ask me about as well. So the trunnion is the junction between the femoral head and the femoral stem in a hip replacement. And because it's a junction, micro motion will occur here. And micro motion causes the taper to wear out and release its metallical particles into the body. So trunnionitis is due to increased torsional stress due to a failure of lubrication. The implant articulation causes higher friction, so the stress is transferred to the trunnion with micromotion, okay? And that's just something to be aware of. It's something which we see more and more commonly. And the other thing that people often ask me about is this thing called run-in and steady state wear. So run-in wear occurs during the first year of using the material, and that's when there's slight mismatch between the two surfaces, despite them looking congruent. So you're going to get more wear as the two surfaces accommodate to each other and the rough bits are worn off. And then basically you get elevated metal ions for about a year. And then as they've accommodated to each other, you get a lower background level of steady state wear before it eventually fails with rapid wear before failure. Okay, so I always think of it as a pair of shoes. When you put on new shoes, it's quite painful because your foot and the shoes are trying to accommodate to each other. As bits of your foot wear off, as bits of the shoe wear off, you start to get a steady state wear after that, okay? And that's the diagram that I want you guys to remember for the exam. It looks very complex there, but if you break it down, like I said, into mechanical, chemical, modes, types, local, and general, you will never go wrong. Now, Asam, how are we for time? Because I was going to quickly go through the fate of the wear particles and osteolysis, but I can call it a day there if we're running behind a bit.
Yeah, you can carry on, Doctor.
I'll be very quick as I can. So guys, we've talked about how the wear particles are produced, but the important point is what is the actual fate of the wear particles? And the buzzword for the exam is osteolysis. Osteolysis is basically a histiocytic response to the wear debris. It can occur for lots of different reasons: infection, aseptic loosening, but ultimately what happens is macrophages get activated. They cause release of lots of cytokines, IL-1, IL-6, TNF-alpha, TGF-beta, and essentially they cause osteoclast activation via the rank ligand system. I'm not going to go into that in a lot of detail, but that causes wear away of the bone. That will then cause micromotion between the two surfaces, which will increase the wear particles by positive feedback because you've got more motion, and then that will eventually get disseminated into the effective joint space, sitting in the fluid around the joint, and eventually catastrophic failure. So size of the particles definitely matters, and we look at the 0.5 to 5 micrometer range because that activates the macrophages. So we look at volume of particles, the number, the size, what their morphology is or shape, and what the individual's immune response is. And I break it down into 4 stages. Stage 1 is how you generate the wear particles. Remember my diagram: mechanical, chemical, modes, types. 2 is activation of the macrophages, the rank ligand system. 3 is prosthetic micromotion, positive feedback, more particles generated. 4 is dissemination of debris into the effective joint space, and there's a positive feedback cycle over and over again until you get catastrophic failure. Learn the different bearing things for the exam: metal on poly, ceramic on poly, ceramic on ceramic, metal on ceramic. And in summary, guys, remember, tribology is important. It's not only important to know about the materials, but you must know how they interact safely. Keep it simple. Remember the triumvirate: friction, lubrication, and your ultimate goal, wear. Okay, thank you once again, guys. Check out our website. Please take a picture of the QR code as well, and any questions to the chat as well. Thank you. Great.
Thank you very much, Doctor. I would ask Dr. Abton Alvand to present his, to share his presentation.
Good morning, Asam. Can you see my slides?
Yes, Doctor, very clear, and your voice is clear as well.
Great. Good morning, everyone. Good morning to everyone in Doha and India. Thanks again to Asam, Dr. Shamsi, and Dr. Galib for the opportunity to talk, and thanks again to the other panelists so far. There have been some excellent talks. So my name is Abton Alvand. I'm a knee surgeon in Oxford, and I hope to take you through the basics of knee biomechanics over the next sort of 15-20 minutes. So the aims of the study of this talk is we'll talk about the biomechanics of the native knee, what the general goals of knee replacement are. I'll touch on knee prosthetic design and also how they would fail, and also just touch on some concepts in revision knee replacement. What this talk isn't about is how to do a knee replacement or how to do a revision knee replacement. We can have another webinar about that hopefully in the future. So biomechanics of the native knee. Well, the native knee is the largest joint in the body. It's composed of the PFJ and the tibiofemoral joint, and it's more complex than a simple hinge joint. It has 6 degrees of freedom, and as you can see in the diagram here, infrasuperior translation, flexion, extension, rotation, mediolateral translation, anteroposterior translation, varus valgus rotation, and internal external rotation. So this is kind of touches on why knee replacements have traditionally not been as successful as their hip counterparts. So for a normal knee, what do you need to be able to do? In a normal knee, generally, if you can get more than 100 degrees of flexion, you're able to function very well. You only need around 65 degrees to walk, just over 100 to be able to climb downstairs. And for some societies, such as for cultural reasons and religious reasons, you definitely need to be able to kneel, and you need to be, and that is between 120 to 140 degrees. Now, if you have a fixed flexion deformity of your knee and you can't straighten your knee, you put this increased energy through your quads and hence increased energy expenditure. So it's very difficult to function with a flexed, partially flexed knee. And the knee goes through a lot of cycles depending on your age and activity level, but generally it's around 1 to 5 million cycles a year. In terms of the joint reaction forces, in the tibiofemoral joint, you have 3 times your body weight, as you can see here, and so double that with stair climbing and running. The patellofemoral joint, the cartilage in the patella is the thickest in the body, and you can see here that the forces, especially when going downstairs and squatting, are tremendously high compared to just normal walking. So the stability of the normal knee is a complex 4-bar linkage consisting of the femur, tibia, patella, and these stabilizers include the menisci, collateral ligaments, the cruciate ligaments, and also a complex gliding and rolling movement, which I'll go into in a minute. But that's all dependent on the articular geometry of the femur, of the knee itself. And so if you look at these 2 CT scans, sagittal views, medial side on the left, you can see here, lateral side on the right, and the blue circle is the anterior part of the femoral condyle, and the red circle is the posterior part of the femoral condyle. And you can see on the medial side, the femoral condyle is larger and extends more distally on the coronal plane, and it's more uniform radius of curvature. And this keeps the medial femoral condyle in place during flexion. Whereas on the lateral side, the condyle is smaller and it's distal and more, and the distal and posterior condyles differ in their circumferential radii of curvature. And so the central rotation of the posterior condyles is closer to the posterior cortex, as you can see here in the red circle on the right-hand side. And this therefore helps femoral rollback. So what about the tibial side? As you know from your anatomy, again, the medial compartment on the top here, you can see it has a larger and more concave shape, and it enables stability of the medial femoral condyle during deep flexion. The lateral side, again, is smaller and is convex, as you can see here on the skyline view from the cadaver. The right-hand side of you is the lateral plateau with the lateral meniscus, and the left-hand side is the medial meniscus. So what about the femoral rollback we talked about? Well, it's a combination of rotation and translation. You can see it very nicely in this dynamic MRI scan. And the purpose is to essentially increase the lever of the quadriceps muscles mechanism. And therefore, it allows clearance of the femur from the tibia in deep flexion. Otherwise, you'd get the posterior femoral condyle bumping into the posterior aspect of the tibial plateau. And then during extension, as the femur rolls forward again, and the increasing lever arm of the hamstring then acts as a brake to preventing you from hyperextending. So this femoral rotation and rollback was highlighted very elegantly by a set of cadaveric and MRI studies from Mike Freeman and Vera Pinskrova from London in the late 90s, early 2000s. And they showed, as you can see from this diagram, that the lateral femoral condyle rolls back across the tibia, and the rollback on the medial side, on the medial femoral condyle, is very small. And this leads to essentially internal rotation of the tibia in relation to the femur as you flex your knee. And so the rotation of the lateral condyle is around the medial compartment during flexion. So I call this the medial compartment is king. Everything else revolves around it during knee movements. What about the screw home mechanism? You might be asked about that in the vivas. And essentially, this is external rotation of the tibia around 5 degrees on the femur during the terminal extension in order to be able to lock your knee. And this happens because the medial tibial plateau articular surface is longer than the lateral side. And that allows you to stand, lock your knee for maximal stability, and it allows you to tighten your cruciate ligaments. And then when you try to bend the knee again, contraction of the popliteus initiates flexion again by causing internal rotation of the tibia and unlocks your knee. What about alignment? Well, you can see in this diagram here, we've got a diagram of the long-standing view of the mechanical axis and the anatomical axis. With regards to the mechanical axis, this is very simple: hip center to the center of the ankle. And if a neutral mechanical axis, this has to pass through the center of the knee. And this is important because your distal femoral cut during knee replacement is perpendicular to your mechanical axis. And therefore, and this is for biomechanical reasons to allow good loading of the sound loading of the knee. The mechanical axis, however, is not parallel to the vertical axis. It's about 3 degrees off it. And the vertical axis is a line from the symphysis pubis, you can see here, all the way down to the ground. The anatomical axis is much more simple. Again, it's along the intramedullary axis of the femur and the tibia in the red line you can see here, and it essentially determines the IM rod entry point. And when you look at, when people talk about the femoral valgus cut angle, essentially the anatomical axis is 5 to 7 degrees valgus from the mechanical axis. If you look at these two diagrams in the red here, and essentially your valgus cut angle, which is defined as the angle between your anatomical axis of your femur and the mechanical axis of your femur, is around 6 degrees on average. If you're a very tall person, this is much less, looking around 4 degrees. And if you're a very short person, this is around 8 or 9 degrees. And then on your tibial side, it's very simple. Your anatomical and mechanical axis essentially overlie each other. And again, this is important in knee replacement because your tibial cut angle has to be perpendicular to your mechanical axis of your tibia, as you can see in the white line here. This, you all know this, but again, it's just recap: valgus and varus alignment of the knee. If you have a valgus knee, what we would say is that the center of the knee is medial to your mechanical axis, okay? And on the right here, you have a varus knee where the center of the knee is lateral to your mechanical axis. What about the sagittal plane? Well, the posterior slope of the tibia is usually around 6 to 9 degrees, and on average we say 7 degrees. And this is a line between the anatomical axis of the tibia on the sagittal plane and the tibial plateau you can see here. And this is important and has some relevance in knee replacement design, in that the cruciate retaining designs aim for reproducing the tibial slope for rollback purposes, whereas the PS design try to reduce the slope to prevent excess anterior translation. And you'll see that when you're doing CR and PS knees, you'll have to, the optic will tell you to cut, for example, with a PS at reduced angles, 3 or 0 degrees, for example. What about rotational alignment? So we looked at the coronal and sagittal in terms of the axial plane. This influences your tibiofemoral kinematics and your PFJ kinematics, essentially, and allows you to, again, control your flexion alignment and your stability in flexion. And here are the classic lines that you're often asked to draw. And this is, you can see here, the transepicondylar axis in the red, and it's nicely demonstrated over here in the knee. Sometimes in real life, it's quite difficult to feel, and I always sometimes wonder how accurate we are at reproducing this, but essentially you're drawing a line between your tibia, your medial and lateral femoral condyles, and then a line which you've got your AP axis, which is your white size line, some people would call, which is a line drawn from the deepest part of the trochlear groove to the notch, essentially over here, where the right angle is. And then you've got your posterior condylar axis, which again is a line drawn between the medial and lateral posterior femoral condyle. And essentially this line is useful, but it can be somewhat unreliable in worn knees due to bone wear, and also in hypoplastic femoral condyles, for example. So you have to take that into account when you're trying to do these. So essentially, if you have a perpendicular line and you're able to delineate your mechanical axis or your transepicondylar axis, then you know that you've correctly rotated your femoral component. And the joint line, let's talk about the joint line. This is important because again, you have your joint line is 3 degrees Varus to your relative mechanical axis, and in your tibia you have again 3 degrees Varus, as I discussed. In your knee and in your femur side, you've got the 6-degree valgus plus the 3 degrees, which makes 9 degrees. But in total knee replacement, we simplify things because we cut everything perpendicular to the tibial mechanical axis. Moving on to the patellofemoral joint, it's a complex joint. There's a whole lecture based on this, but in summary, it's very important because the patella engages the femoral sulcus at only 20 degrees of flexion, and essentially beyond, as you flex any further beyond 90 degrees, you have external rotation of the patella, and only the medial facet starts to articulate in the trochlear groove. And that extreme flexion, essentially the patella lies in the intercondylar groove. So you have different contact areas with different varying angles of flexion, and this is why a simple skyline view of the patellofemoral joint may not always show you the degree of PFJ wear and may be unreliable. Patellar tracking is extremely important for total knee replacement. And we have something called a Q angle, which you know about. And this is essentially an angle between the lines drawn from the ACIS to the center of the patella, and then a line drawn from the tibial tubercle along the patellar tendon through the center of the patella. And the angle between these two is your Q angle, normally between 5 to 20 degrees, higher in women. And if you have an increased Q angle, then this is associated with more patellar instability and more pain. Patellar height is another thing to know, and you have to have or use some sort of patellar height index. I use the Insel-Salvati ratio, which is looking at the length of the patella and looking at the length of the patellar tendon, and looking at this, if you have Insel-Salvati ratio less than 0.8, you have patella baja, more than 1.2, patella alta, and these will have implications in your knee replacements, especially in revision surgery and post, and essentially affect your range of movement. Biomechanics of TKA. What are the goals of the biomechanical goals of TKA? One's to restore the mechanical axis of the knee. 2 is to preserve your joint line, maintaining the Q angle, as I stressed, balancing your ligaments, and ensuring a rigid, durable fixation. What are the requirements of a total knee? You have between 15 to 20 degrees of rotation, and you have about 5 to 10 degrees of medial-lateral motion. But essentially, your knee, in order to be able to function, needs to have at least, as I said, 65 degrees to 70 degrees in order for you to be able to walk. And then, as we saw in the previous slides, climbing and descending stairs require slightly higher, and then activities such as squatting and praying would include higher even than that, around 120 to 40 degrees. So just to recap again on TKA alignment, you have your valgus cut angle, which is between 5 to 7 degrees, typically 6 degrees, and this is perpendicular to your mechanical axis. You can see here on the diagram on the right, you've drawn your mechanical axis, and you've drawn your anatomical axis of your femur, and templating beforehand on long leg views, you'll be able to get an idea of what your valgus angle should be and what this is set at when you come to put your femoral jig on. Tibial alignment, again, you have your superimposed anatomical and mechanical axes, and you have a line perpendicular to this. And this is good in that I always draw this to be able to gauge an idea of how much I'm cutting off each side of each plateau. And if you're way off with your estimation intraoperatively, then you have to look back and see whether you've templated incorrectly, or whether there's something intraoperatively, some technical issue that you haven't dealt with. In terms of the alignment, as I mentioned before, you have your 3-degree Varus slope in your obliquity in your tibia, in your native tibia, but you cut 0 to this in order to get a 0-degree perpendicular mechanical to the mechanical axis. And then you have your 6-degree valgus cut of your femur, and essentially that together with your 3-degree Varus would give you a femoral cut that recreates the 6-degree knee angle and is then parallel to the tibial cut in the coronal plane. Your standard bone cuts in TKA are your anterior and posterior chamfers, and then you have your anterior and femoral cuts, you have your distal femoral cut, and then you have your tibial cut, which is the same, in flexion and extension. What about looking at this again in the axial plane? What you want to be able to do is to have a rectangular cut, essentially flexion space, and you again use what we said, your white sized lines, transepicondylar axis and posterior condylar reference line, to be able to gauge your rotation, and by externally rotating your femoral component, you'll be able to get a rectangular cut. Here again, you can see the native tibia is in 3 degrees of Varus. If you cut the femur and without externally rotating it, you would have a trapezoidal gap, whereas by externally rotating it, you get 3 degrees, which is built into your femoral jigs. Essentially, you'll be able to get a rectangular gap, and hence improve your ligament balancing. Another important concept is the posterior condylar offset, which is determined by your anteroposterior sizing of your knee. This acts as to maximize the distance before you impinge on your tibial plateau, essentially. So you have to essentially recreate the natural posterior condylar offset. If you don't do this, and you, for example, undersize your femur, you decrease your posterior condylar offset and you reduce your arc of motion, and therefore you may have mid-flexion instability. Soft tissue balancing is an entire lecture in itself. If any of you want to read more about it, there's an excellent book by Leo Whiteside which goes through this systematically, and it's a very good read. The joint line is extremely important, as I said, for one of the goals. And the joint line, you can see on the left diagram here, there's various ways to be able to estimate the joint line at reference points: 1 centimeter above the fibular head, 2.5 centimeters from the lateral condyle, 3.5 centimeters from the patella, the medial femoral condyle. And the patella isn't very useful for looking at the joint line, because you can have scarring, especially in revision surgery. And so, and patella baja and patella alta can give you a false representation of the joint line. But essentially, if you raise your joint line inadvertently, then your patellar tendon will be functionally short, hence patella baja, and then it will impinge on your poly when you try and flex, and that causes reduced range of motion. Joint line is extremely important in revision surgery especially, and hence these landmarks are particularly useful during those types of scenarios. How do you optimize your patellar tracking? Well, as I said before, your femoral rotation is one. You can lateralize your femoral component. Your tibial rotation has to be adequately externally rotated, as you know, essentially in line with the medial third of the tibial tubercle, and medializing slightly your patella. Briefly touching on arthroplasty implants, two concepts of design that you have to be aware of is conformity and constraint. So conformity is a static concept, and it's how essentially shapes fit together, and it's the degree of contact between two surfaces, and there's essentially a balance between wear and range of movement. Whereas constraint is a dynamic concept, and it tells you about the degree of mechanical stability, and it's the balance between the soft tissues and also increased forces at the implant fixation interface. Implant designs, just briefly looking at the types of implants available. As you go down this list, you have increasing level of constraint. So you have cruciate retaining implants, cruciate substituting or PS implants, and then you have VVC, which is Varus valgus constrained implants, and then rotating hinge and fixed hinge. But you have to remember the degree of constraint depends on the soft tissues, i.e. your collateral ligaments, for example, not how much bony defect you have. So that's separate. Example of cruciate retaining implants, essentially the retained PCL, if it's functioning normally, drives your rollback and allows rotation. It requires a good ligament and a posterior capsule and extensor mechanisms to be functioning well. Requires more accurate balancing. I think every knee replacement requires accurate balancing. So some people say I use a PS because it's easier to balance. You should be balancing your PS and CR implants perfectly, and not just be lazy and use a PS implant just because you can't balance a knee, a cruciate retaining knee. Again, ACL functions replaced by the slope of the poly, and this is a relatively bone preserving knee replacement. With the PS implants, you resect the PCL, and essentially your cam and post mechanism dictates your femoral rollback. And again, I put more forgiving to balance. Again, you shouldn't be relying on your PS to balance your knee. It's probably the commonest implant system used throughout the world, especially in the States. It permits rotation, but again, it has no varus valgus constraint. So if you think you haven't got a stable implant, or you've maybe damaged the MCL, a PS implant's not going to get you out of trouble. That you're just fooling yourself. A semi-constrained or a VVCK implant has some varus valgus constraint. It has some rotational constraint, but again, it requires a functional MCL. It has posterior stabilization, and it forces your rollback, and it has a fairly good jump height. But because of the increased stresses on the bone implant interface, you need to compensate for that by adding stems to your implant. And then you have the rotating hinges, which is when ligaments are deficient, such as MCL or LCL insufficiency. And again, they have obviously varus valgus constraint and AP constraint. There is no rollback here. There is a little rotation, but again, you need stems because of the transfer of forces through the implant interface. And then fixed hinge implants, I think there's very little, there's a few indications for these, probably in using a total femur, and also in patients with, say, neuropathic joints like polio. Again, for patients who have deficient coronal stability, and this is fully constrained. There's absolutely no rotation, no rollback, and really high implant loads and stresses, and therefore it's used very often. I've used it on polio cases on a few occasions. How do implants fail? Well, Rishi very elegantly described the process of aseptic loosening. Commonest cause of late implant failure is TKA failure is implant loosening due to osteolysis. Septic failure is the commonest cause of early failures, less than 2 years in the registries. Instability can be due to poor offset, the posterior condylar offset and balancing, not balancing your gaps. Periprosthetic fractures can occur in the supracondylar lesion region, for example, due to notching and again poor and referencing. And then you have patellofemoral maltracking problems and joint line problems, which we discussed. Concepts in revision knee replacement surgery. In short, you have to find the cause of the failure and correct it. There is no point in undertaking revision surgery without knowing why the implant failed, because it's deemed to fail again. But just touching on it in slightly more detail, this involves adequate exposure at the beginning and adequate soft tissue coverage at the end, where the need it be with the help of plastics, implant extraction, hopefully with minimal bone loss, restoration of any bone deficiencies that you've caused, and then based on those biomechanical principles, restoring your mechanical axis and your joint line and balancing your ligaments, ensuring that you have good patellofemoral joint tracking, and also ensuring that you have stable implant fixation, and whether that be with long stems, cemented or cementless. In terms of fixation, there's a couple of concepts to be aware of. There are 3 zones within the knee: the zone 1, the joint surface; zone 2, the metaphysis; and zone 3, the diaphysis. You can see in the blue, and there are various implant technologies out there, such as sleeves on the top here to cones in the bottom here, which allow you to adequately restore your bone stock. So that's pretty much it. Thank you very much. Sorry, it was a bit of a rush. I was just trying to catch up.
Thank you very much, Dr. Upton. We'd move to Dr. Shamsi. So Dr. Shamsi, you can just share your presentation. Please unmute first. Dr. Shamsi, yeah, exactly.
You can hear me now?
Yeah, I can hear you, and your presentation is there. Go ahead.
No, it's the other one. Sorry. Give me a second, Isam. Yeah, okay. You can hear me, Sam?
I can hear you, but the presentation is not shared.
It's coming on my screen. This one?
Probably.
You can see.
No, you need to press on share, and you need to select the presentation.
Yeah, okay, now?
Yeah, it's shared.
Okay.
Exactly, yeah. Yeah.
Okay. I'm sorry, guys, we are going a bit late, but I didn't want to stop the speakers because all the topics are very important. And believe me, these are the topics they ask for the FRCS and the boards. And they ask every point Rishi, Jaya, and Abs has talked about. So I'll be talking about implant selection, total arthroplasty. I'll stick purely exam oriented, and luckily or unluckily, I had to give the exam twice. And every slide in my presentation, they ask questions both for the Viva and the MCQs. So implant selection in total arthroplasty, I work in Hamad Medical Corporation in the adult reconstruction, the sports unit. So any talk on total hip has to start with Sir John Chandler. In 2007, it was considered as the surgery of the century by the Lancet, and it has about 97% success rate. Proportion of cases done, it's usually 50% hips and 50% knees in Europe and North America, but in some countries it's less than 10%. Like in Doha, we have more total knees than hips, and hip cases are much less.
Sorry, Dr. Shamsi, to interrupt. Just I'm having some, the candidates, they're asking to raise the voice.
Okay. Okay. So proportion of cases, 50% of hip and 50% knees in Europe and North America, and in other countries is less than 10%. So like in Doha, we have more knees than hips, and our hip cases are much less. But you go to UK or US, the cases are almost the same. And when do you do a total hip arthroplasty? When conservative measures fail, when excision of pain generating surfaces, and recreation of a stable biomechanics. What do I want to achieve? Jaya has gone through it. Restore of center of rotation of the hip, restore the biomechanics of the hip stability, preserve the bone stock, appropriate leg length, and primary implant stability and secondary implant stability in case of uncemented. So the examiners want all this point exactly in this order, from center of rotation to biomechanics, stability, bone stock, and leg length discrepancy. Now, success of total hip depends on you have a patient selection, implant selection, knowledge of biomechanics, and surgical approaches. So we have gone through the biomechanics. I'll be discussing only implant selection. Proper implant selection. When it comes to implant selection as a resident, Safa, can Safa hear me? Hello? Safa? These are the exam topics they usually give for primary hip, osteoarthritis hip, metal on metal, AVN, adult DDH, acetabular-femoral loosening, native hip dislocation, Page's disease, and invariably the question goes to primary hip arthroplasty and what implant and why you use that implant.
Dr. Safa, you can speak.
Safa, can you hear me?
Yes, I can hear you.
Yeah, so this is a female, 36 years old. Just tell me what implant will you use for her?
Okay, so we will use uncemented implant.
Okay, fine. Now this is a 56 years old OA. What will you use?
I will go with the cemented, but
okay.
Door classification is B.
Okay, fine. What's this is a 86-year-old female?
I will definitely go with cemented.
Cemented or uncemented?
Cemented.
Cemented. Okay, so see now the X-ray is the same. I just changed the age. So you have told me uncemented because of the age. For this one 66 cemented for the age, and this one. So you just based upon the age of the patient. So that to us used to be confusing for me also as a resident. So how do you decide an implant? Is it the age of the patient, or is it the cost of the implant, or is it the bone stock, or is it what is called a boss factor? Your boss might have used only cemented or uncemented, or your fellowship. Because when I did my fellowship with apps, I learned mainly cemented from them. And other countries, if you do a fellowship in US, they do more of uncemented. And you have hundreds of implants. Now, how do you choose which implant and what do you say for the exam? Because in your training, you might have been trained for cemented or uncemented, but you cannot say in the exam that, okay, I've been using this and I want to use this. So you need to have a proper structure. So your options are, you could have a cemented stem, uncemented cup. That's a hybrid. You can have a cemented stem, cemented cup. That's a total cemented one. And you can have an uncemented cup and uncemented stem. So we quickly go through the principles, and then finally, how do you decide and what do you say for the exam? So first thing for the stem, Lawrence Dorr classified the stem, the Dorr classification that was in 1992. He described 3 type A, that is champagne flute, where the canals with trumpet shaped. Then you have type B, which is proportional, relatively normal proximal distal geometry, advice cementless. And you have type C, which is a stovepipe or large femoral canal. The inter-observer and the intra-observer reliability of Dorr classification changed according to seniority and the experience of the surgeon. It was very low for junior surgeon, but excellent high for senior surgeons. So this one point you can consider when you choose the implant. So you go for THR fixation, you have cemented polymethyl methacrylate. Rishi discussed the principles of cement, and Dr. Sharath also will be going in detail. And you have an uncemented fixation where it's a biological fixation where you have bone in growth or bone on growth. So cement fixation, it can, if you works on micro interlock with the endosteal bone, cement will fatigue with cyclic loading. There's no remodeling. Once cracked, stays cracked. Two interfaces, cement bond and cement implant. Two design philosophies for the cemented hips. You have to know in and out about these two implants. Everything they keep asking in detail about these two implants. One is a taper slip designed by Ling and Lee, the Exeter stem. It does not have a proximal, it does not have a collar. It's polished, and a tapered stem does not promote bonding of stem to cement, allows subsidence. It allows subsidence up to 0.9 to 1.4 millimeter in 12 months, and it gets stabilized within a year. And it also retroverts 0.4 to 0.5. The examiners expect you to know the amount of subsidence also. The sinkage of stem into the cement, what does it do? It causes radial compression created, which is converted into hoop stresses, which invariably stabilizes the implant. It compresses the cement with low shear and low tensile stress, accommodates creep and stress relaxation. The second implant is the Chandler implant, which has got 3 or 4 generations, but the best, most successful was the first one Chandler designed. You have a ref stem to bone with cement. Cement must provide good support and resist shear force generated by loading. Load transmitted through the stem to cement and then to bone. So the stem plus cement plus femur acts as a single unit. Absolutely, there is no subsidence in a Chandler or a composite beam principle. So you can have a cemented cup where the design of the cup is for cementing. You have flanges to compress, and you have grooves for surface area and bonding, and ports to prevent bottoming out. Depending upon the design, deep grooves reduce poly thickness, which may cause stress rises, creep, and fatigue. So if you're doing a cemented femoral stem, it has shown that young active patients have increased risk of failure. Men are 2 times more likely to fail than women. So question is young patients good candidate for cemented, or do we have to go for cementless? So next, you have to know the Deeley and the Chandler zones for the loosening and osteolysis, superior, middle, and inferior. And for the stem, you have to know the Gruen zones and the Gruen's mode of loosening. It was described by Gruen in 1979. This you have to know in detail and to be able to describe the loosening and the modes of loosening like pistoning, cantilever bending, and medial stem pivot. So now we go into the uncemented stem, which depends upon the biological fixation. It's a dynamic process, ongoing bone remodeling and repair, potentially life-lasting, only one interface. Success is dependent upon the design and the technique. So initially you have a rigid implant fixation. There are 2 techniques used, press fit and line-to-line technique. And you have 2 methods. So 2 techniques, that is press fit and line-to-line, and 2 methods. 2 methods are bone in growth, where you have a porous metal, and bone on growth, where you have a rough metal surface, no actual pores and divots. So bone in growth, you need to know the values. Optimal pore size, you have 300, 600 microns, optimal pore depth, optimal metal porosity, and minimal gaps. Easy way to remember is to 50, because everything is 50 microns. And minimal micro motion, that also has to be less than 50 to 150. And maximum contact with cortical bone. It provides an initial rigid fixation by the press fit technique. You have to ream the canal to the size, insert a stem slightly larger in size, typically 0.5 to 1 millimeter larger in size. Press fit technique for the cup, ream established to the size, insert a cup slightly larger in size. Cup is hemisphere in design, typically 1 millimeter larger in diameter, and screws rarely needed. So this is the principle of press fit technique, where you have, it's like a large peg in a small hole, where the compression hoop stresses provides the initial rigid fixation. the example of press fit technique for the stabulum. The second one is the line-to-line technique for the stem. You have an extensive porous coating. Extensive porous coating provides initial scratch fit, and long-term fixation is biological. And then bone on growth, where you have a press fit technique, design typically a high angle wedge taper design, and long-term fixation, which is biological. For bone on growth, it depends upon the surface roughness of the implant. Implant surface roughness determines the strength of fixation, and the linear relation of surface roughness to fixation strength. So now you have a dorsifemur. Again, will you do a cemented or uncemented? If you can do a cemented meticulous third generation technique, or you can do it uncemented, you have care to avoid fracture and to get a press fit. So it is possible to do both cemented and uncemented. So our question still remains, how do you decide the implant? So Haddad 2019 in BJJ, cemented and cementless femoral components both have excellent outcomes if the procedure is performed to an appropriate standard. So this is a general recommendation. If your patient age is less than 55 years, you can use a ceramic total hip replacement uncemented. In the female, ceramic mini hip uncemented. 55 to 70, you can use a ceramic on poly total hip, again uncemented. But above 70 is recommended to use a cemented hip. So we can remember that and say in the exam. But now you have to give evidence. Evidence has to be based upon long-term studies, lab studies, patient satisfaction studies, and patient-related outcome measures. So for that, you need to know something about ODIP and the National Joint Registry. So ODIP provides the NHS with an approved list of processes that meets the revision rate standard at 10 years set out in NICE guidelines. Okay, so what does it represent? It has a number, a letter, and a star. The number, for example, the 7, the 10, or 3. The number represents the number of years for which the product performance has been evidenced. You have from 13 and the 10, but 10 is the full benchmark according to NICE. The letter represents the evidence, that is A or B. Letter A, strong evidence. Letter B is acceptable evidence. And the star was included in the NICE in 2014, in which a benchmark replacement rate of less than 5% at 10 years was defined. That means if you have an ODIP rating of 10A or 10A star, that means they have done a study on 500 hips or knees beyond the developing center, that is more than 3 centers and surgeons. And if you have an alphabet A, that means the failure rate is less than 10%. And if you have A star, the failure rate is less than 5%. So if, for example, these are the common implants used in the hip. Now, for example, you're taking an uncemented step. You have a Corelia, you have a Pinnacle. Both have a 10A star according to ODIP rating. If you are taking a Exeter, you have Exeter here. You have a contemporary cemented cup. Both have 10A. Sam will be talking about the knee part. So now you go to the National Joint Registry. What is National Joint Registry? Is a system of collecting information on arthroplasty outcomes in order to provide evidence base for safe and effective treatment option. It was started by the Royal College of Surgeons England in 2003. Initially, they had only data about the surgeons and the implants. Later, they have included patient-related outcome measures. In the US, the registry started in 2001. Australia 1999, and Sweden 1975. So this is how, if you go to an NJR, you can see the data on any implant. Now we talked about the Exeter, V40, and the contemporary, that is the cemented implant. And you can see the failure rate is less than 3%, it's 2.62. Or you go for a uncemented Correct and Pinnacle, failure rate of less than, in 10 years is less than, it's like 2.58, and you go for a hybrid, that's an uncemented cup and a cemented stem, the failure rate is 2.9%. So now you can mention the NJR, you can mention the ODIP, okay, and you can do cemented or uncemented. The NJR also shows information on the surgeons Like if you want to check on apps, you can go for Abdominal one and check his complication rate or how many cases he has been doing. And you can get information on hip bearings, cemented hip bearings. You can get data on the higher, according to gender, on the age of the patient. And the bearing surface, metal on poly, ceramic on poly, so you can have data on all the implants used. This is an age stratified revision risk from different registries. The registries I mentioned was Australia, England, US. So now when you go into that, you can see the green is a cemented is better. So if you go to Australia, they say above 75 cemented is better, and 50 to 60, they use uncemented. But when you go less than 50, again, they say it's no difference. So similarly in UK, they use more of cemented. So it doesn't matter whether you're using a cemented or uncemented. It doesn't matter in the exam whether you're saying a cemented or uncemented, but you have to substantiate your answer according to what we have discussed from your training, from your fellowship, from your experience, then patient factor and the studies, the NGR and the ODEP. So when you go to the exam, you have to finally have an answer in mind. What implant are you going to, if the examiner asks what implant will you use? This is something apps made for me for my exam last year. So if you go for if you get a primary hip case and examiner asks what implant will you use? So you have to, this is what you have to describe. You will say Exeter contemporary metal on poly. Why? Because it has an ODEP rating of 13 A-star, that means 13 years and high evidence. And the NGR has 97.65 survivorship and 2.5 or 2.4 revision rate. You also can, you have to give evidence for your answer, like what studies. This is again JR's paper on the Exeter and Pennington paper, if you can remember. Or you can say, I will use a uncemented implant that is an Exeter or a hybrid. That's a Trident is an uncemented cup, but which has a 13A ODEP rating and the NGR has 2.7%. You also can say, I am trained in using a cemented, I'm more confident, it is more forgiving. So your answer has to be basically structured, and you have to give a reason why you're using an implant. You cannot just say that because that's what I've been using, that's what is available in my hospital. And you have to know exactly why you are using the implant. Thank you. So next one, Isam will be talking about implant selection knee. Isam, you can hear?
Yeah, thank you, Dr. Shamsi. I'll have a short talk on implant selection and knees. I'll present my desktop. Yeah. So luckily it has been covered a bit by Dr. Abton. So this is a recap of this topic. So to start with, I'll declare that I have nothing to declare. And as you can see here, not all the knees are the same. So all those are primary knees, patients who are walking and complaining of pain. But you cannot just decide the same implant for all those knees, although they look arthritic, but you would offer different implant to the patients. So in order to get a proper implant selection, you have to sit with your patient, take a proper history. You have to do a very good examination. You have to examine the knee in general to know where is the pain and where is the tender point, and what the range of motion is quite important. Ligament instability is quite crucial. And of course, you have to do a proper radiological examination, like an alignment examination and standing views for the particular knee. And you need to know that there are lots of determinantal factors in order to select your implant, but patient symptoms, limb alignment, ligament status, and bone loss are the most important things. So again, some patients with severe arthritis, asymptomatic, maybe you can offer them non-operative treatment. Patients with bad alignment, you would know that they would have some kind of ligament instability, and you would offer them more constrained implants, while patients with severe bone loss, you might offer them more constrained. So to start with the unicondylar knee arthroplasty. So unicondylar knee arthroplasty is a simple procedure, like it's a procedure or the surgery that can preserve the knee kinematics to a high extent, but it has some prerequisites. You cannot offer knee unicompartmental arthroplasty to any patients, but you need to have you have to select your patients quite carefully, because this kind of implant, doesn't have the survivorship like the total knee. So you need to select the patients quite wisely. So one of the things that you need to know about that, you make sure that the patient doesn't have any symptoms or any arthritis in the other compartment. The osteoarthritis that you can find in your patient shouldn't be inflammatory by all means. So you need to exclude any rheumatology condition with your patient. The knee should be stable. I mean, it has to have has good ACL and BCL, good collaterals as well. Although some surgeons, they may overlap, or they may just not focus much on ACLs, but the gold standard that you should have good ACL, good BCL, good collaterals for your knee. Mild malalignment is acceptable, like 10 degrees of correctable varus and 5 degrees of correctable valgus. Could take unicondylar knee. You have to have good range of motion, preferably from 5 to 90 degrees. So you shouldn't admit patients with a fixed flexion deformity, or patients who cannot bend their knees as much to unicondylar. Patients with history of meniscectomy in other compartments, like patients with you're planning for medial compartment of arthroplasty, and the patient had a history of meniscectomy in the other compartment, shouldn't be admitted for that. BMI is questionable again, but it's not preferred to take patients to operate on patients who are above 80 to 85 kgs. So the preferable BMI should be over time less than 32. Age again is questionable, but again, you shouldn't take very young patients who are doing lots of activities, who will worn out their knees quite easily. And it's better that you didn't also take old patients who are may have other compartment arthritis. So age is a subjective issue. You need to look carefully on it. So looking at the NGR registry for the primary unicondylar or patellofemoral knee. So as I've mentioned earlier, it's a very good implant that it gives very good relief for the patients, but survivorship of this implant is not comparable to the total knee. So unicondylar fixed implants, usually they survive at 15 years. They have a failure rate of 15%, while the mobile ones, they fail in 18% of the patients at 15 years, according to the 2019 registry. So what would you select for your patient, mobile or fixed bearing devices? So going into the literature, so we're having some literature that they were initially supporting mobile or fixed, but the highest or the best evidence now doesn't prefer or confirm any advantages of mobile bearing over the fixed bearing. Again, another study, which is the highest evidence available on meta-analysis, it comes with the conclusion that current literature doesn't show any significant difference in the clinical outcome between the medial and lateral mobile fixed bearing unicompartment arthroplasty. Then there were some studies advocating unicondylar arthroplasty along with anterior cruciate ligament reconstruction at the same time. There is no strong evidence for that, although it has been advocated by some surgeons. But again, the evidence available for that is very weak, and you cannot rely on a strong discussion. Then we go into the total knee arthroplasty. So lots of controversies. How would you counsel your patient? What implant would you select? Cruciate retaining or BS or posterior stabilized knee? Mobile or fixed bearing? Cemented or cementless or hybrid? Then would you resurface your patella or not? And finally, what about bicruciate retaining total knee arthroplasties? So when you see to both knees, so you can come up immediately that it's very unlikely that you will select the same implant for those patients. Although the X-ray on the left side, it looks very uniform arthritis, no much deformity, and those patients can come up with, or can get up with the less constrained implant like cruciate retaining. Looking at the X-ray on the left side, or the right side of the screen, so there's so much bone loss. There's some bone loss and so much deformity, and it's quite difficult knee to balance with a cruciate retaining knee. So you would just keep in your mind that you would prefer posterior stabilized knee. From the AB view, they look the same if you select the same manufacturer. On the lateral view, you can see that the posterior stabilized knee has a boss and cam, while in the cruciate retaining one, you can see very simple implant without any box here. Sorry, the pictures are reversed. So some implants or some manufacturers, they don't have those boxes are radiolucent, and you cannot diagnose with the X-rays. So this is how PS knee look like compared to the CR knees. Again, you have to make sure to look carefully for the box and the cam, where they get the stability by the integration between the polyethylene and the box here. So going into the literature again, we have one strong meta-analysis published in 2019. It came up with that both prostheses, they provide feasible and safe solution to the end-stage degeneration. There's no difference in terms of range of motion or functional outcome, and there's no dissimilarity between both implants. Then, what would you select, mobile or fixed bearing? So theoretically, when fixed mobile bearing devices came into the market, they were advocated that those kind of implants, they allow for better range of motion compared to the fixed bearing devices. So they rely on the mobility on the polyethylene, so they're trying to mimic the natural behavior of the knee joint while moving. So it allows some rotation of the polyethylene over the tibial tray, some AB and ML translations. But again, when it comes to evidence, there's no difference, and the benefit of increased rotation or range of motion of the mobile bearing is only theoretical. Another randomized controlled trials of 9-year follow-up comparing fixed versus mobile bearing. This is the longest published follow-up, and in practice, the superiority of mobile bearing implants is solely theoretical. Again, another 6 to 10 years follow-up of prospective RCT, just showing the same thing, that they concluded that the best design is the one that the surgeon is most comfortable and most able to implant reproducibly. Then going into another argument, cemented or cementless or hybrid. So going into the NGR registry, you can see that cemented prostheses are far done most, and more than 80% of the total knee arthroplasty are cemented compared to small fraction of cementless prostheses. When they're comparing both implants again, they find no difference. So looking at the revision rate in primary total knee arthroplasty and cemented implant, you can see that the best survivorship is for the unconstrained fixed bearing total knee arthroplasties at 15 years. And sorry, the best survivorship is for monoblock polyethylene tibias with 3.48% compared, followed by the unconstrained fixed bearing with 4.38% revision rate at 15 years. When we're going into uncemented or hybrid knee, the best survivorship is for the unconstrained again, but it's very a small difference between the both implants. It's for the unconstrained one is 5.9%, and just smaller fraction better than the unconstrained mobile one. The posterior stabilized fixed cemented uncemented prosthesis, they have lower survival rate at 15 years compared to the CR knees. So what about the patellar resurfacing? Would you resurface all patella, or you should be a selective resurfacer? So on the recent last published meta-analysis or level 1 evidences, they were advocating more towards resurfacing all of the patellas, but because they're claiming that reoperation rate is higher with unresurfaced patella. But again, you can see here the 2019 meta-analysis, it shows that the surface patella has better value of knee society score and hospital special surgery scores. However, they mentioned that unresurfaced patella, they have better range of motion. Going into 2018 evidence, they showed that there is no difference, but any better outcome of resurfaced patella would be unreliable because of the heterogeneity of the included studies. Although this evidence is not as strong as the 2019 one, but again, so it's still controversial topic. I think patellas who are really damaged need to be resurfaced, and to be selective for that is the better answer, as there's no differences as such. Again, going to the same slide, showing the percentage of implant used with, in comparison between cemented and uncemented ones. I'm showing the same table that Dr. Shamsi showed, but this time for the knees. And there are those are the 15 years survivorship of different implants. You can see here the best survivorship is 3.48 for the monobolic polyethylene tibia in cemented prosthesis, followed by the unconstrained ones. Then I'll just small touch on the bicruciate retaining knee. Those knees were in the market in the past, but they were not as successful. They're getting a bit back into the market, but again, there is no strong evidence. Initially, the claim was those implants, they just mimic the natural knee regarding the ligament stability. But we had one study here that shows that it doesn't show that those kind of knee, they shown to mirror the native knee more closely, but the clinical outcome doesn't differ significantly compared to the knees with sacrificing the ACLs. But those kind of knees, they're a bit more challenging. Going into more constrained implants, so you need really to know how much bone loss you have. We're having the Anderson Orthopedic Research Institute knee bone loss classification was quite important, and it can show how much bone loss, and you can study how much bone loss you're having in your knee, and you can plan the prosthesis accordingly. This is a very nice table where you can really decide the type of prosthesis according to the bone loss and to the laxity. Like here, if you're having a stable knee with minimal bone loss, you can use non-stabilized or stabilized knee. If you're getting more laxity, you can go into more like stabilized than the Varus valgus constrained. And if you're having like MCL and all other lateral collateral ligament are gone, then you have to think about hinged knee. Again, when you go more with the bone loss, if you're having, usually you're having absent PCL, so you have to think about hinged knees whenever you have very severe bone loss or laxity. Looking at this knee, it looks like this is a native knee of a gentleman who's been complaining of severe pain and feel of instability. When you just see this kind of knee, the MCL is gone, BCL is gone, and you have to go into some constraints as you don't have much of bone due to the bone loss. Those are other types of knees where the Varus valgus condyle are stabilized knees. You can combine those kind of knees with stems, cones, sleeves, some augments in order to get correction of your bone loss. Again, you need to use a stem on both knees because of lots of stress, as been mentioned by Dr. Upton. Those are the augments and the augments that you can add to the femoral component, and the wedges that you can add to the tibial tray in order to compensate for your bone loss. This is the sleeve. The sleeve is usually is unique for each manufacturer, and it gets connected to the tibial tray and stem by a more stable technique. Hence, you cannot use a sleeve of one manufacturer to the other manufacturer compared to and you can add different types of stem sizes according to the diameter and bone loss. And those are the cones, trabecular cones. You can compensate the bone loss with them. They get, they're facilitating bone growth around them, and you can fix them to the implant with a cement. This is an example of femoral and tibial cones. This is a very nice table that I really liked. So, so it speaks about ligament integrity and degree of the constraint. So in patients with BCL, you can use BCL retaining when you have all the ligaments like PCL, lateral, collateral ligaments, and good quads. And you can just go more constraints whenever you lose any of those ligaments. Like, for example, you can go for posterior stabilized knees whenever you don't have BCL while other ligaments are good. The VVC knees, you can use them if you don't have the MCL, but you need to have a lateral collateral ligament. And you choose the hinged knees if you don't have none of the ligaments. So this is the Varus valgus condylar stabilized knee. You can see that those kinds of knee, usually you need to apply stem with it to resist the force. And they're having bigger box and cams in order to stabilize the varus and valgus force. More hinged prosthesis is the hinged knees. So those kind of knees, they're having axles and screws where the knee is quite completely controlled in terms of varus and valgus forces, and it allows for one motion only. Then finally, after you know about the different constraints and different types of the knees, you need to choose your manufacturers. So most of the manufacturers, they're having, like the well-known manufacturers, they're having good knees in general, but it's very useful to know, as Dr. Shamsi mentioned, the degree and the degree of survivorship and the evidence behind each of them. So again, so Genesis is having 13A plus compared to NextGen, which has 13A, followed by the BFC knees, which is 10A plus. This is the end. Thank you very much for your attention. I hope that I didn't take much of time. So I would ask Dr. Sharath Rao yeah. Dr. Sharath, do you hear me?
Yeah. Thank you, Isam, and thank you, Shamsi.
Thank you, Doctor. Thank you for
having me here. So I'll just start my slides.
Yes, share it.
Okay.
Your screenshot.
Maybe you need to click on that presentation, Doctor. Just open it in the background.
Yeah.
and just share it directly.
You share. Yeah. Is it okay now?
Yeah, it's very clear.
Yeah. Thank you very much. So this talk is mainly on cementing technique, especially in hip and also into the knee, and how to do it right way. Basically, this talk deals about the cement and what development has occurred over a period of time as far as cementing technique is concerned, from first generation to the fourth generation or so-called modern generation. And where is the indication for the cementing technique, and what's the best way or the right way to do this technique? So basically, we anchor the processes to the bone. Either you can do a cemented total hip replacement or an uncemented total joint replacement. You can do a hybrid femoral component, where femoral component is cemented and the stabular component is uncemented, or sometimes a reverse hybrid where femur is uncemented and the stabular cup is cemented. How do you choose? Shamshi has explained about the DORS index, where it gives a guideline for you to select, especially when you have a poor bone quality, poor bone stock, especially in chronic inflammatory diseases, stovepipe of femur, there's DORS C. When you have done a tumor excision and there is bone defects or previous fractures or osteotomies where tight fit may not be achieved using a customary uncemented implants, and sometimes in revision hip arthroplasty. This has been explained to you by Shamshi, where most of the time in C you select a cemented stem, and in B sometimes if the need arises you can also switch over to cemented stem. Father of modern arthroplasty, Sir John Chandler, is the one who popularized what is called low friction arthroplasty, and especially the use of polymethyl methacrylate for fixation of cement. From the time of its origin, advances has occurred in the knowledge of the bone cement, the availability of type of bone cements with different characters, preparation of bone cement, how to prepare them, and techniques of cementing. This is, over a period of time, our understanding in cemented total joint replacement. What is important to understand is cement is a grout, not a glue. And even Sir John Chandler has said it. Bone cement has got no adhesive properties to either to the bone or to the implant. It just gives a mechanical bond between the bone and the implant. So it anchors the processes to the bone as a filler. It transfers the load from the processes into the bone. It absorbs forces, and sometimes, as the case is needed, it might deliver antibiotics. What is actually happening when you put a cement? Integration of cement into porous cancellous bone, and when it integrates into the cancellous bone and then hardens, by that time it produces a micro interlock mechanism. So to produce this, the cement has to move into these pores under pressure. So the pressure usually which is needed is under about 100 kilopascals. If you look at the cement, it basically comes in two forms, powder and the liquid. The powder is copolymer based on polymethyl methacrylate, that is PMMA. And liquid is a monomer. Solid is polymer and liquid is a monomer of both methyl methacrylate. Powder and liquid are mixed as a ratio of 2:1. So you'll find half the amount in grams as the liquid when compared to the solid. So what are the different components what you have in powder and liquid? As I said, powder is a polymer, liquid is a monomer of them. So you need to have an initiator for the reaction which occurs when you mix them both. That is in the powder, formed by benzoyl peroxide. There is an accelerator which continues this reaction in the form of DMPT. Then, because when you take an X-ray, you need an opacifier. So there is barium sulfate and zirconia oxide in powder, which is radio opaque. There is a stabilizer, which is hydroxyquinone, and the antibiotics can be added in the powder form whenever you use this. So what does actually happens? The initiator and the activator produces free radicals. So these free radicals cause polymerization of the monomer, which is in the liquid. This is an exothermic reaction where the temperature can reach up to 90 degrees. So even if the temperature is reduced by irrigation or putting saline into the system, it will continue to polymerize. So whenever you make a cement, it has got 4 phases. The mixing phase, which is up to 1 minute, where powder and liquid are homogenized. Then there is a waiting phase, which can last several minutes, where the cement will reach from sticky phase to non-sticky phase. Then the working phase, where it is non-sticky and you can work with the cement. And that's the most important phase for the surgeon to act. And then the hardening phase, or the final setting phase. So all these phases, or basically polymerization, can be affected by the temperature, moisture content in cement, and humidity. Let us look at this graph, which tells you what happens if the temperature goes down, or if your theater temperature is at 19 degrees, you have a good working time with the cement when it is non-sticky. So the working time goes on decreasing as the temperature goes up. So it is important to keep the temperature controlled in a theater to see to it that you have a good working time for the cement. So what are the other effects? Higher the moisture, faster it will set. You see, if you look at the cement pouch, you will have the outer foil, which is moisture barrier. So if you open the cement and keep it outside for a longer time, then it will set faster. So just open it only when you start mixing it, just before mixing it. And where do you store it? And you store it in such a way that moisture do not enter this. You store it in a dry ventilated place at around 6 to 23 degrees of temperature. So exposure to higher temperature will produce partial polymerization and maintain the theater temperature between 19 to 21 degrees to have a good polymerization and have a good working time with the cement. If you look at the viscosity, higher the viscous, shorter the wetting time, longer the working time, and you have clinically better results. So you choose a cement also depends on this. So when you put the cement, it is important that when you put a cement in high stiffness, no interdigitation will occur because it will not penetrate into the pores. When it is high flow or more viscous, when you put it, the blood will displace it. So there is an ideal time when you put the cement so that it penetrates and also interdigitates when it's put in. So how did this is about the cement and its character. But what developments has occurred over a period of time in preparing, in application of the cement during surgery? The first generation, which was popularized by Chandler, was an open bowl technique, where cement is mixed on an open bowl and then picked up and introduced by hand. There is no medullary canal restrictor. There is no understanding of viscosity. There was a constant digital pressure which was maintained for the cement and the processes for integration. Let us look at how it was done. Open the liquid pouch first, put it on a ball, and that is the monomer. Open the powder pack, put the polymer into it, mix the entire content. No partial amounts should be used because they are meant for each other and it is in the same pack. Stir with the spatula vigorously for 30 seconds. Wait till the cement does not stick to your rubber glove. Knead further for another 15 to 30 seconds. Now becomes more homogeneous when you do that, and the air bubbles will escape. And now it is ready for cementing. What happened after? We came to know about interdigitation, how the cement should enter the pores in the bone. So we tend to have a bone bed preparation, irrigation and drying. So there's no blood pushing the cement out. Medullary canal restrictor, so that when you put the cement and pressurize it, it moves sideways into the bone in the medullary canal. Retrograde introduction and proximal femoral cement pressurization. All these to have a good interdigitation in the pores. Continuous pressure was used by Charlie even then. Retrograde filling was done even later by Robin Link. So you have taken the best practices of first and second generation techniques, and when we have the modern generation technique. Now, if you look at the best cementing technique or right cementing technique has got 4 pillars. Bone cement, understand the bone cement. How to mix it and deliver it. How to prepare the bone bed. How to pressurize, and I will add how to pressurize and put the implant. So these are the 4 basic pillars on which your success of cementing stem depends. So, pulsatile lavage for cleaning the femur, medullary canal restrictor, vacuum mixing, I'll come to vacuum mixing a little bit later, of bone cement, cement gun and proximal femoral pressurization, and use of centralizers. This is almost 4th generation method. Vacuum mixing, why vacuum mixing? So this decreases the cement porosity and fume exposure. The monomer, when it is mixed with the powder, produces fume, and that is bad for the eyes. So exposure to fumes are reduced. Decrease in porosity increases the tensile and fatigue strength of the cement. Just look at the difference between open ball and vacuum. Mixing time remains the same. Start of duct phase decreases when you do vacuum. End of application phase also decreases, but you have enough time for working time, and hardening also decreases. Time also decreases. So it's a quick application, safe application when you do vacuum mixing. What about plugging the bone canal? Using a cement restrictor. Cement restrictor can be a bone, a plug of cement, or even a polyethylene can block. So it will prevent the extension of the cement column when you put the cement. And when you have a restrictor and you put the cement and pressurize it, there is a uniformity in the cement column is achieved. This cement plug is usually applied around 2 centimeters distal to the tip of the stem. Not advantageous to have it go beyond 2 centimeters because it will have a problem when you do a revision, because you might have to expose a longer area which otherwise would have been not exposed. Cement caulking gun. Caulking is a method by which you fill the gaps, or in your floor in your house, you use a caulking gun to fill the cracks. This gun helps in retrograde filling of the canal with the cement. There is less chance of air entrapment, gives improved cement strength and fatigue life, lowers the risk of aseptic loosening due to cracks in the cement, and less exposure to monomer fumes. Modern guns also permit vacuum mixing. Start with the plug, and nozzle you do not plunge. You put the nozzle near to the cement restrictor and start pushing, and your nozzle should be pushed away by the cement itself rather than you pulling it. If you pull it, it creates voids and air bubbles. The 4th generation used centralizers, distal centralizer and also proximal centralizer. This maintains the normal or uniform circumferential cement. Moreover, prevents valgus and varus of the stem. Helps in survival of the processes for a long time. This tells you how we have moved from 1st generation to 2nd generation to 3rd generation, and now on the modern cementing technique with the 4 pillars, that is 4th generation of cementing. All for the advancement has occurred so that the survival of the processes is more. Dr. Shamshi has already explained about this. There are tapered stems and non-tapered stems with the scratch fit. So what happens when there is a flat taper and a dual taper? Dual taper is an exeter stem, and you even have a triple taper now where it's a C stem. There is a better filling up of the canal when you use a dual taper and a triple taper. So this is the basic two types of cemented stems. One is the exeter system where it has to subside, and about the subsidence, Dr. Shamshi has already explained. Other one is the scratch fit, where the cement bonds between the stem and the bone, where there is no subsidence. Look at the acetabular designs. There are grooves, vertical and horizontal, which will increase the surface of the cup for better hold with the cement. There are PMMA pots, or the eyes, which go into your drill hole system. There are wire markers which can tell you about the inclination and antiversion in the radiographs. There are flanges and the rims which aid in the pressurization. Make your bone bed dry. Use a hypotensive anesthesia. Dilute epinephrine or adrenaline if the anesthetist allows you. Hydrogen peroxide. Drier the bone, better the integration and microlock of cement to bone. Few controversies. Here is the one where in the acetabulum you have retained the subchondral bone, where you have removed the subchondral bone. Which is better? This is what interdigitation of the cement occurs. When you retain the subchondral bone, this is how it looks on the back side of the cup. And when you remove it, it's how it looks. So interdigitation naturally is better when you remove the subchondral bone and the cement penetrates into the calcareous bone. Look at the X-ray. One side you have where you retain the subchondral bone, on the other side you have cement where you have not retained, and the cement has, as if it has splashed into the bone. And you have an immediate fixation, which is very strong in this case where you have removed the subchondral bone. And this is what exactly you want in the acetabulum when you look at the X-ray, how the cement has penetrated. Pulse lavage, remove all the blood debris, dry the acetabulum, pack with hydrogen peroxide or adrenaline soak pack, prepare the cement. Once cement is duffy, does not stick to your glove, remove the pack, wipe it dry, insert the cement with the hand or the gun and push the cement to fixation holes. This is how it is done. And you get a uniform cloudy cement of at least 2 to 5 millimeter in diameter around, which will last long. And remove the excessive spilled over cement from the edges. So this is how it's cleaned, packed. Then you put the cement and pressurize a balloon where pressure pushes the cement into the, and then insert your cup, maintain the required antiversion. And if you look at these three types of cementing, there's adequate good cementing in the first X-ray, insufficient cement in the second X-ray, and excessive cement in the third X-ray. So the likely failures are more in the insufficient and the excessive version. How do you prepare the femur bed? A good, clean, stable, bony bed is important for cement interdigitation. Ream the femur, broach the canal. Broach itself creates a 2 to 3 millimeter envelope around the processes which size you select. After you broach, you can put a centralizer, keeping it around 2 centimeters below, cement restrictor 2 centimeters below the tip of the processes. Plug the canal, high pressure pulse lavage. Look at what it does when you use a high pressure pulse lavage. From this, it creates this. As a result, the blood is not there. Cement easily goes into these pores, interdigitates. Reduce the amount of debris, blood and fat. That is what the pulse lavage does. And then you can even use the brush to clean the area. Use a cement gun, fill it from the bottom, and then let the cement gun be pushed by the cement itself backwards. You can use a pressurizer, femoral pressurizer on the top. Blood is enemy of good cementing. Blood pushes the cement from these pores out and prevents interdigitation. So initial small pressure to push the blood out and high pressure later to produce interdigitation and maintain this pressure. So these are the steps which I've already mentioned. A small suction tube can be put in the canal when you put the cement, and 2/3 of the cement is filled up in the canal. Then you can slowly remove it from the area so that you can visualize it. This will reduce the amount of vacuum or the air which is created inside. There are surgeons who do few drill holes on the proximal femur and suck that area to reduce the pressure and prevent the fat embolism. You can cut the nozzle of the cement gun and use it as a pressurizer on the proximal side. And then the stem is introduced with a centralizer, both distally and proximally, according to the 4th generation technique. And you hold the stem with the stem holder, maintain the version till the cement hardens, after removing excessive cement with the help of the curette. And this is what you want when you do cement. Interdigitation, interlocking between the pores in the bone and the cement. What's the thickness of the cement? Ideally, 3 to 4 millimeter cement mantle have the best stress curves. Bilateral hip, bilateral cemented stems, double taper, exeter type, done. Good cementing of the scapula, white out in the femur, no place for osteolysis, uniform cementation all around the femoral stem. And again, another example using a different type of stem with the cement applied. There are drawbacks of cement. It generates heat. It can fragment. There is foreign body reaction. There may be prosthetic loosening. It might induce chronic inflammatory response. These are the Gruen zones which are described in the cement, especially where you look at the loosening in a cemented stem. A little bit about cementing in totaling arthroplasty. There are wide variations in the technique. But remember that tibial loosening is 4 times more common than the femoral loosening. So, cementation of tibia is more important than cementation of the femur. Whether to use a cement gun or finger or even a spatula. Whether you should fully cement the process, tibial processes, that is both surface and stem, or only do surface cementation, that is only the undersurface, not the stem portion or the keel portion of the process. Cement both the implant and the surface, or only the bone, or only the implant. Whether to use a pulsatile lavage, definitely drilling the sclerotic bone will definitely help. Ideally, cementing both the surface of the bone and also full surface of the processes, including the stem, is ideal. But there are no randomized controlled studies to prove this. Again, on the femur, on the processes, and also on the surface of the bone. Negative suction by making drill holes in the tibia, no difference. And apply the cement in wet phase only. Simultaneously both for femur and tibia, and then pressure in extension for interdigitation. There are many methods which are described. No cement on the surface, surface on the cement only on the surface. No cement on the bone, but cement on the full surface. Cement both on the bone and on the surface applied by spatula. Cement both on the prosthesis and bone surface, finger. And cement both surfaces, but by the gun. So these are different techniques which are usually it is individualized. No much of difference between each method. What are the complications of cement? Hypoxia, hypotension, cardiac complications in the form of arrhythmia, myocardial infarction, pulmonary embolism, bronchospasm, cardiac arrest, and cerebrovascular accident. This is mainly because of the embolism, microemboli, which reach the lung during cementation. This occurs during pressurization, during implanting, and also during reduction. During reduction, when these cement particles which are in the blood get released immediately into the system and goes via the venous plexus into the lungs. Fat embolism, release of histamine, and finally go into anaphylaxis. Other complications like contact dermatitis, hypersensitivity reaction to liquid component, extrusion of cement locally can produce hematuria, bladder fistula, sciatic nerve entrapment, local vascular erosions, or thrombophlebitis. How to avoid the complications? Meticulous irrigation and drying of the canal. Do not over pressurize. Monomer vapor is highly inflammable when you are mixing the cement with the help using the liquid. Caution while using cautery when you are mixing the cement. Irritation of respiratory tract, eyes, and liver during mixing. You can do a vacuum mixing and avoid it. Avoid wearing contact lenses while mixing the cement to avoid fumes from the monomer. Thank you very much. So, shall I go on to the cases?
Yeah, thank you very much, Dr. Sharath. Yeah, please go on.
Thank you, Dr. Sharath. We are extremely grateful in your busy schedule. I'm sure you'll be sitting in the Dean's office and doing this now.
Yes, exactly. You're right.
I know that. So we'll go on with the discussion, short discussion.
Yeah.
So Dr. Sharath will be discussing a few X-rays for the residents. Okay.
Yeah. So, okay. So let us start with this X-ray. So you have already asked the question to Safa. So there's somebody sitting in front of me here in Dean's office. So I'll ask him to start with this. Yeah, tell me about this X-ray.
X-ray of pelvis with focus showing deformation of the right femoral head. It's also partially subluxated with there's a deformation of the femoral head also. We've broken the broken central line.
Yes. So that means there is subluxation of the hip. Okay. So what do you think about the soft tissues which are there around the hip? What exactly has happened to the soft tissues? Looking at the X-ray.
The soft tissue contracture which has probably helped in the subluxation of the.
Yes. So you should look at the pelvis. Pelvis is tilted. So there is a adduction deformity of the hip, a subluxation of the hip. So leg is short, but leg may not be as short as it looks because of the adduction deformity. And there is a fixed flexion deformity. Look at the obturator foramina, exactly. And which is, so you plan your soft tissue release and also whether there is a requirement for an adductor tenotomy. It is required when you will do it, whether initially you will do it before you start your surgery or at the end of your surgery. So subluxation is there, and there is a subluxation and an adduction deformity. Your abductor lever arm is increased. So you have to get the center of the hip your abductor lever arm equal to the opposite side. All these points you have to look into when you do. This is a 46-year-old man. Okay, so what do you think? Looking at the canal, will you prefer cemented, uncemented, or hybrid?
Type C.
Yeah.
And age is 46.
Yeah.
We can go. It's been proven in younger age we go for uncemented, but here we can go for hybrid.
Okay. So when you say between door C and door B or any classification, you look at the inner canal diameter on the middle of the lesser trochanter and inner canal diameter 10 centimeter below the lesser trochanter. So this diameter, inner canal diameter 10 centimeters below the midpoint of the lesser trochanter divided by the intercortical or inner canal diameter at the midpoint of lesser trochanter. If it is anywhere between 0.75 to 1, that is almost double, it becomes door C. So this X-ray, if you calculate, it will be somewhere between door B. And also look at the opposite side, because it is important that the patient is not using the other side. So there is always a chance of little bit of osteoporosis on the other side, which will regain that bone quality later. So looking at the opposite side also, making a decision is important. Okay, so what you're actually looking at is you have to reproduce the center of the hip. You have to regain the length. So you calculate how we are going to reproduce the length in this patient, offset and abductor lever arm, how you're going to do it. So this is what you do. You want to get it right. When you draw the center of the canal and center of the hip, you want it to get it right. And this is what was done. It was an uncemented hip which was done here. And you look at the offset almost like the opposite side has been reproduced. And you also note that now the operator foramina has come back. So these deformities, which are secondary to the soft tissues, will come back over a period of time when the patient starts using it. It may not be evident immediately post-operatively, but when the patient starts walking slowly over a period of time. So that also you have to keep in mind when you correct the shortening. You have to give it to the deformity part. You have to take it out, and actually the true shortening is the one which you correct. And also because when there is a subluxation, the abductor lever arm has been increasing. Okay, so you have to reduce the abductor lever arm to the original side. So when you recreate the center of the hip to the original center of the hip, and luckily you have a normal side on the opposite side, it's easy to compare. So when you do that, you will definitely have a good long life for the implant when you do a stick. So this was somewhere done in 2001, almost 18 years without any problems has survived in the patient. And again, the length, which is important, maintain the length. When you maintain the length, do the surgery, get a good result. So have a good anteversion. So offset, anteversion, abductor lever arm, sweet spot in the head. All if you recreate, just like original hip, your hip will last more than. There is no reason why the hip should fail rather than telling that it should last. Okay. So Shamshi wanted very quick discussion. So let us concentrate only on the one side, that's on the right side. You have.
Yeah, you want to select anybody, doctor?
Yeah, Abdul Aziz is here, doctor.
Okay. Abdul Aziz. Yeah, you are allowed to talk, Abdul Aziz.
Hello, everyone. Thank you, Dr. Rao, for the chance.
Yeah.
So right here, I see an AP of bilateral knees.
Yeah.
We can see there is significant deformity with bone loss
Yes.
And the right knee, a significant deformity involves the medial condyle.
Yes.
And the left knee, it's mostly involved in the lateral condyle. It's most likely like a windswept
Right.
deformity.
Yes.
So in this kind of knee, I'm concerned for the collaterals, and I
Yes.
don't think the primary designs might be adequate to correct any deformity here, and I would need to increase the level of constraint in the devices.
Okay. So you will preoperatively assess the medial collateral and see how the medial collateral leads. And there is a laxity on the lateral side. There is also a little bit of lateral subluxation. And if you look at the line, it almost stops here and almost the medial condyle as if it has disappeared. Okay. So you have a large defect. Now look at this lateral view. I'll show you only on the right side. You look at the lateral view, you have defect more on the posterior side. Okay. So look at how the defect starts. It's almost on the posterior side. And so you will keep what are the things you will keep ready apart from the primary? Primary, you are thinking of either cruciate sacrificing.
To be honest, in such knees, I will be reluctant to do any primary knee.
Yeah.
I'll be erring on the side of using more constraints such as a Varus valgus constraint, or if things are not really that good, such as a global instability, I should have a hinged knee as well.
Okay, yeah. So I still remember Asham's slides, one beautiful slide, which gave you the directions of what exactly to use when you have medial collateral, the problem, lateral collateral problem, quadriceps, and then when you don't have even the quadriceps, what are the options? I think this is a situation where definitely, as you said, Dr. Abdul, you keep your constraint ready, either Varus valgus constraint or even the hinge. But to start with, go that you are trying to use not constrained ones. Okay. Whenever possible, I will try first to use a cruciate sacrificing one. Cruciate retaining is out of question because of the deformity. And if it is not possible to do it on the table, it's easy to change over to the. This is what exactly has been done. So there was a defect on the medial side. So the defect was filled with the graft obtained from the cut using and you used a stem for the better stability, and then the processes of this, and this is the lateral view. So always try to use the normal implants, and if you are not able to use it, then go ahead for the one more constraint. Okay. So, Yankee, you want to take this or?
Again, extension involving bilateral
It's around 36 years old. Okay.
Professor Rao, I'm having comments that the voice is not clear.
Okay. His voice is not clear. Okay.
Okay. The next of the pelvis with bow flips of a 36-year-old gentleman with bilateral broken shin tendon with the obturator foramen suggestive probably of the inclination, suggestive of the flexion deformity of both hips. The right greater trochanter is at a higher level than the left side, and the femoral head is deformed. The right side appears to be more involved than the left side. It has a type DOE A classification. Given the age, I would go for total hip arthroplasty of the right side, probably an uncemmented one.
It's good. So you look at this X-ray when compared to the previous X-rays of what you have seen. Previous X-ray, you could use a stem, you could use a cup, and you could use a modular head, okay, to get the modularity, to assess your limb length, you assess your, to adjust your offset, and then you finish the surgery. Here is your modularity only in the head is not sufficient to do this case, because a normal prosthesis will not enter this femoral canal. Now, this is a case of spondyloepiphyseal dysplasia. So, I'm just taking you one step further of modularity that in the hip system, which is also important when you start doing cases which are difficult primaries. Now, if not revisions, at least difficult primaries where the canal and the metaphysis do not match with each other. The version of the neck do not match with each other. So this is a spondyloepiphyseal dysplasia, and you can see in the X-ray, see the acetabular dysplasia, but the medial wall is so thick. The acetabulum is almost not formed. Okay, so whenever you are dealing with such types of cases, he has got a very narrow canal. So there is a diaphyseal metaphyseal mismatch. So you need modularity in the stem, not a single piece of stem with a different head size, but you might have to use a different version of the neck, a different version between the metaphysis and the diaphysis. So you might have to use a stem which has got a different diaphysis, adjustable metaphysis and adjustable neck and adjustable head, where the modularity of the stem comes into play. So this was done. So if you look at it here, it's, as you said, it is unsymmetric. So this is a modular portion of the diaphysis of the stem. This is the modular portion of the metaphysis of the stem. This is the modular portion of the neck of the stem, and this is the modular portion of the head of the entire stem. So how does this modularity help you to adjust things according to the mismatch which has occurred in a difficult primary case? So this case I have put just to explain to you about the modularity varieties which can exist in the stem, and this is what happened, and this is how it is, and this is after 5 years, and this is almost after 10 years. Now if you look at it, it has been medialized when you have done it, because to create a new acetabulum, the medial thick wall has been moved. Okay, so this has survived well for a long time. So it's nearing lunchtime for you. I think, Shamshi, I'll just leave you with this case to discuss during lunchtime what to do. So this is a patient.
I'll have to keep thinking till dinner then, sir.
Yeah. So
no, for the previous hip case, is it possible to use a DDH stem and do a cemented, like do a hybrid for that?
You can do it, but since it is a young man, the chances of loosening are quite high. It was in the beginning to use a DDH stem for all these, and all these now acetabular dysplasias or Crow 4, we tend to use only the modular stem, at least 4 pieces together.
Okay, sir. Okay.
So think about it, and the next time I will start the talk with this X-ray. Okay.
Yeah. Till then, we'll keep thinking what to do for this.
Yeah. Thank you.
Thank you, sir. Thank you, all, everyone. I hope this was useful for all the residents, both in Manipal and here. I assure you, this is the most common topic discussion for the first year exam and the board exam. These are like a must know. You have to know whatever we have talked today, even the basic science, you have to know the biomechanics, you have to know the free body, you have to know the NJR, you have to know the auto plating, cementing techniques, all are basics. It's just that if they ask any topic and you don't know, you feel you'll end up thinking it was a very easy question and it was like, I don't know why I failed. So you have to know all this. So Dr. Ghalib, can we?
Yes, Shamsi.
Any comments?
Thank you very much. Just at the end of this comprehensive webinar, we'd like to thank all the faculty, starting with Isharat and Abtin and Jaya and Rishi, and of course Shamsi and Aysam for their time and effort to make this successful, this webinar successful and comprehensive. And also would like to thank the attendants for the participants for their attendance, because without attendance and without a participant, then the webinar will be not successful. Thank you very much, and we hope we will do another more webinar in different subject about the basic science in the other orthopedic subjects. Thank you very much.
If the Manipal PGs, if they find it useful, I mean, I will like to do some more topics like basic trauma, and just let me know. I'll contact Sandeep regarding the same. Thank you, everyone.
Thank you, guys. Nice to be involved. Thanks again. All the best.
Thanks.
Thank you very much. Take care, everyone. Bye-bye.
Thanks.
Okay, Jay, thanks. Isam?
Yeah, Dr. Shamsi.
Thank you, Isam.
Thank you very much.
I'll come and kick you.
Inshallah.
Shamsi.
Yalla. Was it good, Dr. Ghalib?
Well, it's good, very good. But it is very long. Yeah,
This topic, next time we'll make it to. Next time we'll make it short. Next time we'll do trauma and we'll make it short. Only case discussion.
People, they cannot tolerate more than 1 hour.
It's for the residents. It's for the residents, not old people like us.
لا قصدي يعني مثلا for example this we can make it 2 hour, one مثلا session about the hip and the other but different. But it was very good يعني subject, especially biomaterial and يلا. Thank you very much.
Yalla, thank you, Dr. Ghalib. So we'll plan something.
Inshallah.
Something smaller. Thank you, everyone.
Thank you, Asam.
Thank you, Dr.
عصام انت صورتك منورة يا عمي.
تسلم دكتور، نور نورك.
ما شاء الله، الله يبارك فيك. يلا السلام عليكم.
حياك.
Okay.